for the 5th time this year. And thank you for joining for the inauguration ceremony. May I request the following dignitaries to please come on the dais. I request Reverend Pearson. I request Professor Mark Ranjan, Associate Director, Admin, CMC Vellore, Professor Nihal Thomas, Head of Department Unit 1, Professor Thomas Paul, Head of the Department of Endocrine, Professor Asha, Head of Endocrine Unit 2, Dr. Felix Jebasing, Associate Professor, Dr. Kripa Elizabeth Cherin, Associate Professor in Endocrine, to please come on stage. So all good things begin with a prayer. I request Reverend Renard Pearson to please begin with a word of prayer.
Good evening. Let us bow our heads and look to God in prayer. Yes. Gracious God, our Heavenly Father, we thank you so much for this beautiful day. We thank you, O Lord, for the opportunities and the new avenues that you provide at various point of times in our lives. Lord, even we thank you for the Ministry of Department of Endocrine and CMC. We thank you, Lord, for this program. And we want to thank you for all the delegates. Thank you for the safe journey that you've given to them. Lord, even as they be here for another 2 days, we pray, O Father, that they will have a wonderful time of learning and fellowship. We pray that all that we learn will end up providing care to the sick and suffering in this country and even beyond. Give us, O Lord, a meaningful time of learning together. We pray this in Jesus' precious name. Amen. Yes.
Thank you, sir. I now invite Dr. Felix Jebasing, Associate Professor, Department of Endocrine, to give the welcome address.
So good evening, ladies and gentlemen, and on behalf of Department of Endocrinology, Diabetes and Metabolism, Christian Medical College, Vellore, we welcome you all for this academic feast, which is going to happen over the next 2 days. And we also would like to welcome Professor Mark Ranjan, our Associate Director for Admin, to come and grace this occasion. Thank you, sir, for coming. And we will also like to thank Reverend Pearson to come and have our prayer with us. And especially we would like to welcome Professor Nisha, Professor Abhilash, and also Dr. Philip Finney, who has come all the way here to be a faculty, and also welcome who have been online for this session. And welcome you all again. Hope to have a great day ahead. Thank you.
Thank you, Dr. Felix. I request everybody on stage to please start with the lamp lighting. Thank you all. I now invite Dr. Asha to give us an overview of the masterclass program.
Welcome you all to this fifth masterclass conducted by the Department of Endocrinology at CMC Vellore. So this masterclass would include various case discussions, debates, panel discussions, as well as small group discussions, which you have witnessed today, as well as tomorrow, the workshops which are sort of hands-on. In addition, we will have a quiz at the end where you can get attractive prizes. The focus has been on common areas which are required for endocrinology training, as well as we have included some aspects which are not commonly covered in all medical colleges during training. Some of them would have the opportunity to have seen those cases, while some would not have. So we have tried to incorporate these aspects as well. And of course, after a long time of COVID, I think this is one of the places where you have met peers from other colleges, where you have the opportunity to interact and learn from each other. Once again, welcome you all and hope you have a good academic feast over the 2 days. Thank you.
Thank you, ma'am, for that overview. I now invite Professor Nihal Thomas, Professor and Head of Unit 1 in Endocrine, to give a message to all our endocrine trainees. Where is endocrinology headed towards? I invite you, sir.
Thank you, Nitin, for that introduction. And the question was, where is endocrinology headed? And if you want an honest answer from me, I don't know. But perhaps we'll try and reflect a little bit over the next few minutes and see where we are actually going. I remember my initial forays into considering a specialty beyond medicine as a career ahead. And we were told by many role models that never to look at life ahead as a career, but as a service and a vocation. In fact, reflecting on the past, many of us took up endocrinology to consider diseases beyond the normal realm of general medicine. We considered possibilities which are more exotic and unusual, things such as inborn errors of metabolism and quasi-syndromic ecstasies. Little did we know that the meandering course of life would lead on to focus on diabetes and thyroid disease. The dimensions of all specialties in medicine and the approach to handling these problems and different diseases gets transformed decade by decade. For example, cardiology was way back in the 1970s, largely clinical in nature, wherein the cardiologists did periodic angiograms to decide the suitability of patients for rheumatic heart disease and congenital cardiac disorders, to help the cardiothoracic surgeon wield the knife after splitting open the rib cage. Echocardiography, high technology cath labs, devices, and stents. And today, of course, the epidemic of coronary artery disease has changed all that. And by the 1990s, there's little room for the hapless cardiothoracic surgeon to maneuver. Prior to the 1970s, the life of the neurosurgeon was as rough and tough as anything else. Not that it is very much different today, but to perceive that you could locate or diagnose a brain tumor purely on clinical neurological skills and doing the occasional pneumoencephalogram seems beyond belief for the contemporary clinician to comprehend. But these are all facts based on the memoirs of the figurative academic grandson of Harvey Cushing, who trained Paul Harrison, who in turn trained Jacob Chandy, who was the founder of neurosurgery in Vellore. All these events were part of what happened to be barely a single generation ago. We have been privileged in the last 2 decades to see that coupled with spectacular techniques of imaging like ultrasound of the thyroid, positron emission tomography, and MRI with innumerable forms of isotope imaging, the diagnostic endocrinology is entirely different from what it was 20 years ago. The rapid turnover of hormonal assays with chemiluminescence is a paradigm shift from the days when we used RIA done exclusively in accredited laboratories and waited for nearly 2 weeks for a result of a TSH, 3 months for a parathyroid hormone, and 6 months for a growth hormone level. A significant quantum of decisions as to proceed for parathyroid or pituitary surgical intervention were based on empirical biochemistry and judicious clinical thinking. So we've come a long way since then. So with the proliferation of other medical subspecialties over the country and the growth of technology, what is going to happen to endocrinology as a specialty over the years to come? Should we be impervious to change? Should we wait for the evolution of our specialty to take a ballistic trajectory and fall like a rock from top of a cliff and gain autonomous momentum from the forces of matter? Or should we conveniently piggyback with the industry that is churning out a myriad of molecules and claim ourselves merely by way of hedonism to be the sole proprietors for their usage? Which is appropriate? Really speaking, determination of our future in endocrinology lies in our own hands. As Marcus Brutus said, and pay careful heed, there is a tide in the affairs of men, which when taken at the flood leads on to fortune. Omitted, all the voyage of their life is bound in shallows and miseries. On such a full sea are we now afloat, and we must take the current where it serves or lose our ventures. The profundity of this Shakespearean quote is worth ingeminating. Let us lay aside the stereotypes of current thinking and develop an engaging stratagem to outline our own unique role in the field of medical specialization. We must evolve a sui generis that outlines our individuality. At the foundation of it all, let us remind ourselves that we are fundamentally one of the few specialties that encompasses the breadth and depth of internal medicine, the kaleidoscopic environment of the lab, the perpetuality of medical genetics, and the ability to constantly innovate. All you people are extremely innovative, creative people, and that is why you have taken up the specialty of endocrinology. A few examples of our uniqueness involve some of the spectrum of what is covered in this workshop. Osteoporosis and metabolic bone disease is an exciting field wherein therapeutic adjuncts, densitometry, and bone markers are well evolved and paradoxically yet being defined. The endocrinologists of the future should play a bigger role in bone protecting and healing amalgamations, which will evolve further, and the specific categorization of treatment will vary dependent on formation, resorption, the age of the patient, and the underlying clinical condition. The foot in diabetes is a zone which continues to remain pungent and unholy for the vast spectrum of the medical and surgical fraternities. The putrid soles and repugnant ulcers that fester deeply and lead to permanent disfiguration and dysfunction of the lower limb offers a massive opportunity for healing, offloading, and a myriad of other interventions. Herein lies the secret of systems development, and all that needs to be done as a team. The importance of the orthotist, the diabetes educator, the physiotherapist, and the endocrinologist all are very important, and they function as a team. The importance of having more manufacturing units across the country, something an endocrinologist should play more of a role, is really very, very important. The integrated management of obesity beyond the four walls of pharmacotherapy, involving the integrated collaboration of the endocrinologist with the pulmonologist, psychiatrist, and dietitian in making a well-rounded figure less round, forgive me for the pun on the word, is very, very important. Now, let us bravely venture into the zone of pituitary disease, wherein the 7 hormones of the command gland form a potpourri of disorders. A medical crossword worth solving for many patients, and the challenge of working with the neurosurgeons with skill, but varying from charm of an endocrinologist. Last but not least, we may remind ourselves of the importance of genetics in the management of our many patients. The importance of sequencing, the florid interpretation being something which needs the teamwork of a well-trained laboratory scientist, hand in glove with the endocrinologist. Personalized therapy or a vast number of conditions ranging from diabetes to DSTs will happen. The endocrinologist of the future should be well-versed with genetics and skilled in lab technology to make a difference to the community. Finally, let us remind ourselves of the words of William Osler. Medicine is learned by the bedside and not in the classroom. Let not your conceptions of disease come from the words heard in the lecture room or read from the book. See and then reason and compare and control, but see first. When William Osler made these pronouncements, there were no Zoom meetings, no YouTube videos, no ebooks or Kindle or no air travel. But the element of truth in these words still rings loud. The amount of time we spend with our patients is absolutely paramount. Ladies and gentlemen, welcome again to Vellore. And in the time that you spend here, be sure to visit the wards with our residents, if you are passionate to do so, and see the vast spectrum of patients if you have the inclination. Have a wonderful time and have a wonderful evening. Thank you.
Thank you very much, sir, for those words of wisdom. It'll stay with us for a long time. I move on and now invite our chief guest for the evening, Professor Mark Ranjan, who's the Associate Director of Admin at CMC Vellore, to address the gathering.
I have the honor and privilege of introducing Professor Mark Ranjan. Professor Mark Ranjan is an absolutely astute administrator who's currently Associate Director for Administration, which is one of the most important administrative positions in the institution. He is a colorectal surgeon by profession and has trained in the wonderful center in Colchester in the United Kingdom. And he's here to preside on this particular occasion. Over to you, Mark. Thank you.
Thanks, Nihal, for those kind words of introduction. I must say it's a privilege for me to be here on behalf of the director to grace this occasion of your inaugural ceremony for this 5th masterclass in endocrinology. So as was said, I'm a colorectal surgeon, which is as far away as possible from endocrinology as you can get. And it's actually a bit intimidating for me to be standing here in the midst of a room full of physicians. Now, endocrinology, Nihal told you, gave this lovely overview of how endocrinology, he sees endocrinology growing from here on. Now, I'll take you back into the past a little, and it's a testament of how your specialty has grown and how the Department of Endocrinology has grown. So when I was an intern, there was no Department of Endocrinology. So there was the General Medicine Department, and there were a couple of 2 or 3 individuals who were interested in endocrinology. And at that time, we always looked at them as a bunch of weird guys who only thought of exotic, outlandish things and went in touch with reality and whose feet were not on the ground. And diseases like diabetes and thyroid disease were left not even for the medicine consultants to manage. Diabetes definitely was left to the interns to manage. And those days, diabetes was easy. I was an intern at that time, and there were only 2 drugs apart from insulin. There was Dionyl and glyphosate, and the rule of thumb was all the fat people got glyphosate and the thin people got Dionyl. And that was very easy. And then when they didn't get control, we would go on to insulin. Now, having seen that and seen where you all stand now, the trajectory that this department has shown and your specialty has shown has been amazing. And I think among all the medical specialties, I will stick my neck out and go so far as to say you probably had the steepest trajectory and the most rapid growth over the years. And over the last 20 to 30 years, the department started in 1995. So we are looking at 25 years now, little over 25 years. You've reached a point where you're one of the leading departments in the country, and the field of endocrinology has become one of the most sought after fields among young physicians. And I'm so glad to see all of you here, eager to learn what has been taught. And on behalf of the institution, I'd like to welcome you all to CMC Vellore. I'm sure you'll enjoy the experience over the next couple of days. I'd like to welcome you all to this masterclass, and let me assure you, you are among the masters. So I'd like to commend the Department of Endocrinology in CMC Vellore I'd like to welcome all the external faculty to our institution. And I'd like to especially take this time to welcome each one of the delegates. I wish you all the best for the next couple of days and for your careers and your futures as endocrinologists. All the best and God bless you all. Thank you.
Thank you, sir, for those very kind and insightful words. I now request Professor Thomas Paul, who's the head of the Department of Endocrine, to tell us about the masterclass journey we've had over the last 5 years.
Thanks, dear friends, and thanks, Dr. Ma. I won't take much time. I think over the last 5 years, we incorporated, in addition to the clinical cases, we had some panel discussion, as Dr. Asha mentioned, some syndromes and all that. This time we incorporated debates and duologues and workshops. And my special thanks to faculty who have traveled, and we welcome you, and all the other faculty who are joining us online. And so many people work behind this. So all my department, my students, all of them, and so many external. So hope this will be beneficial for all of you, and we'll keep in touch. Okay. All the best for the rest of the evening.
Thank you, sir. I now invite Dr. Kripa, who's Associate Professor in Endocrine, to give a vote of thanks.
On behalf of the Department of Endocrinology at CMC Vellore, I'm privileged to propose the vote of thanks for this evening. We're grateful to God for providing us circumstances conducive to this program to be conducted in person. And today we are privileged to have with us the distinguished presence of Professor Dr. Mark Ranjan sir, chief guest, who's actually taken time off his very busy schedule to grace this occasion today. Thank you, sir, once again for being with us. I would also like to thank Reverend Pearson from Chaplaincy CMC Vellore, who's been a part of this inaugural ceremony. Words cannot express enough our gratitude to all our teaching faculty who've agreed to join us both on site and online. Dear teachers, your presence is much valued. No academic program can be successfully conducted without the continued support of a good technical team. And in this context, I'd like to thank Mr. Shrikant and Mr. Kamesh from the Vellore Online Systems, Telemedicine, Mr. Ravi and the Audiovisual Department, and the Tamil Nadu suppliers for making due arrangements for this program to be conducted here. I would also like to express our gratitude to all our industrial sponsors for their very generous contribution. Our association with the Darling Group of Hotels goes a long way, and I would like to take this opportunity to thank them for making arrangements for food and refreshments to be provided at the venue. A word of appreciation to all our secretarial and support staff on the floor, as well as all our patients from whom we continue to learn every day. I would also take this opportunity to thank Dr. Aaron and his team from the molecular lab, the DEXA technicians, and the diabetes educators who are involved with various aspects of this program. Postgraduate students from across the country, really students, you are the strength of this program, and we feel honored to have you here with us. I would also like to thank my colleagues and other faculty from the department, Dr. Nihal sir, Asha madam, Dr. Felix, Doctors Ramya Jensen and Sindhu for their very valuable contribution. Dr. Thomas Paul, professor and head of the department, and Dr. Nitin, they have really worked tirelessly over the last several months to put this program together. Once again, thank you all and have a good day ahead.
Thank you, Dr. Kripa. And with this, we come to an end of the inaugural ceremony. I thank all the dignitaries for sparing time for this inauguration ceremony, and we shall now start the academic program. again request for all those who've not yet registered for the quiz to please register. They're really attractive prizes. Just to announce, the first prize is a cash prize of 20,000. Second prize is a cash prize of 15,000. Third prize for the team is a cash prize of 10,000. So you'll have a preliminary round today at the end of the sessions at around 8:30, and the selected teams, 4 selected teams, would go for the final round tomorrow. For each of the sessions, as I've put in the group, that we also request a couple of postgraduate students to be seated here in the first 10 seats, as we may call it, as the hot seat for each of the case discussions, so that everybody gets a chance to interact with the faculty. And we shall invite those PGs for each of the sessions. Today we have 2 case discussions. So we've already sent you categories, and the category D1 and D2 would be invited for the first 2 sessions on Turner syndrome and Cushing syndrome. So just as we set the stage, we'll take a 2-minute break and then start the session. For the first case of Turner syndrome, I invite the following students, 9 students, to please come and sit in front. I invite Dr. Aditya Gautam, Dr. Aditya, Dr. Joel Franklin, Dr. Akhila Bhandarkar, to please come and have a seat here. Dr. Avivar Avasthi, Dr. Neeti Agarwal, Dr. Manjunath, Dr. Sandeep Kumar, Dr. Rohit Banbas, and Dr. Yashasvi. I have the privilege and honor to invite the faculty for the first session of the Endocrine Masterclass. We have Dr. Abhilash Nair, faculty from Trivandrum Medical College. Thank him for traveling all the way and joining us in person, who will be the first faculty. And I also invite Professor Pramila Kalra, who has joined us online. And she's professor and head of Ramaiah Institute of Medical Sciences from Bangalore. Our first case presenter for the case of Turner syndrome is Dr. Harshita from Ramaiah Medical College. I invite her to come and start the case presentation. Just a quick audio visual check. Dr. Pramila, ma'am, can you hear us?
Yeah, hello everyone. Nice to be there as a part of the faculty for the masterclass. Am I audible?
Yes, ma'am, you're audible, very clear. Thank you, sir. Over to Dr. Harshita.
I hope we are also audible to you very clearly.
Yeah, I can hear. Yeah, thanks.
Ma'am, first, can we go for the initial part of history?
I think we can, yeah. We can go with the history, the basic thing, and then we do start the questions. Yeah.
Okay, thank you. Yeah, Dr. Harshita, please start.
Good evening, sir. Good evening, ma'am. I'll start the presentation, sir. Ms. K, who is a 30-year-old lady who is single and who has studied up to 9th standard, hailing from Vellore, presented initially at the age of 15 years with history of poor development of secondary sexual characters in the form of poor breast development, no axillary or pubic hair, and she has not attained MENAC. These were her chief complaints, sir.
So she has come to you with the poor breast development and
no axillary or pubic hair, ma'am. And
but they are not bothered about anything about height or anything. No, that those things parents are not bothered.
Actually, it was not a chief complaint, but that was also one of the concerns, but that did not make them come to the hospital at that time.
Okay.
Can I elaborate?
Yes, yes. We'll discuss.
Yes, ma'am. I'll start from the antenatal history, sir. She is third born. She has two elder siblings who are brothers out of a third degree consanguineous marriage. There were no history of maternal PIH or diabetes or infections. She was born out of a full-term normal vaginal delivery with vertex presentation. It was a hospital delivery. The birth weight was around 2.5 kgs. The birth length was not available. And she cried immediately after birth. There was no history of prolonged neonatal jaundice, no seizures or hypoglycemia. There were no signs of failure to thrive. She was feeding well. She was breastfed for 6+ months. And her childhood history is that she attained milestones appropriate for age. And at around the age of 7 to 8 years, she started having recurrent right ear discharges. Initially, it was serous, and she was treated with antibiotics intermittently for the same. And she started having purulent discharge at around the time of this hospital visit. And she ultimately underwent a surgery for the same, probably a mastoidectomy, sir.
So what was the age of the mother when she was when she conceived, when this girl was born? What was the age of the mother?
Ma'am, she was in mid-20s, ma'am.
Her mother. Okay.
Yes. The patient
is that history important? The age of the mother when the child is born, will it be related to anything?
I think that questions should be answered from the
residents. Yeah.
Dr. Aditya, can you answer?
The chance of development of Turner's.
Good.
The increase in age increases the risk. Increase in maternal age.
Okay. Okay, please go ahead.
Yeah.
Ma'am, do you have any other questions?
No, we'll go ahead. Then we'll discuss. Let her finish. Then we'll have to discuss. Yeah.
Okay.
So Harshita, she only had this history of ear discharge. There was no other problem till the age of no other issues. Her schooling, everything was going on fine, no problem.
Yes, ma'am. I'll just talk about her schooling in the next few lines, ma'am.
Okay.
The patient herself noticed that she was shorter than her peers when she was studying in high school, and she noticed that she did not have a growth spurt in her high school like her other classmates. And she, mother as well as patient herself, at the age of around 15+, noticed that she had very poor breast development without axillary or pubic hair. She studied till 9th standard and discontinued because she had some difficulties in language as well as mathematics. Those were her concerns, and that is the reason why she quit school. At the time of presentation, that is around 15 years, she also had history of constipation. She had a history of easy fatigue and excessive daytime sleepiness, but there was no history of postural giddiness, no history of recurrent headaches.
At what age?
Yeah.
So at around 15 to 16 years.
Okay.
But why did you ask this? Can you tell us why? Can the residents tell why she asked about this history of postural giddiness?
Joel Franklin.
What is the importance here, or what things are coming to her mind?
Constipation, hypothyroidism, and this GI disturbances. Celiac disease can present sometimes with isolated short stature and all that.
How common is hypothyroidism, you think, in patients? See, basically, we are moving towards a case where there is primary amenorrhea,
and short stature.
So, is it more common in any type of disease because she is having those symptoms?
Autoimmune
hypothyroidism, that will help you in link. Can be suggestive of, can be more suggest you towards Turner's. Okay. Yeah.
Yeah, any other things coming to the mind? Now we have this much of history. So from the resident's perspective, like, okay, one thing is like there are features that the girl has come with primary amenorrhea. So we are evaluating and we're thinking in terms of Turner's. Any other things come to the mind at this point of time? We haven't examined the patient as yet. We don't know what are the features. So anything else comes to the mind? We have one history of ear discharge, which may be significant, may not be. So anything else is coming apart from Turner's? Obviously, that's one thing which is coming. But after that, what are the differential diagnoses which are coming up in your mind?
Dr.
She
Akhila?
was giving some negative history also, that there was no hypoglycemia and things. Probably we are also thinking in terms of multiple pituitary hormone deficiencies.
Correct.
Or some factor defects, something which leads to like transcription factor defects. So other hormones also needs to be assessed side by side, since there is generalized absence of puberty altogether.
Right.
So anything else, like apart from that, what are the differential diagnoses which are coming up in you? One is the pituitary. So apart from the hormone deficiencies, can there be anything because of which this girl had delayed puberty, she's not growing, apart from the transcription factor defects?
Much more common.
Yeah, overall, like for a delayed puberty, I would want to consider constitutional causes as well as functional, along with the
So what are the constitutional causes which are coming to your mind? Like, what are the causes which are coming? One is pituitary, you said transcription factor defect. That's one cause. We discussed Turner's, hypothyroidism. Then what else is coming to your mind?
CDGP is one thing.
Anything else can happen to the pituitary? First, let us continue with the one thing and then go to the other. So anything can happen to the pituitary?
There can be acquired causes also, like some surgery, trauma, radiation, infiltration, all
That
those
is,
things.
so trauma, apart from that, can it be some other, just something else, something in the pituitary?
There can be some craniopharyngioma, optic nerve gliomas, tracheus cleft cysts, so many other causes can cause.
Something which is okay. Then anything else is coming to your mind? When you think of delayed puberty with short stature, what all causes come to your mind? So basically we have to list those causes and then we have to rule it one by one. That's how we have to go.
Any other person can answer? Avivor, sorry.
So are we thinking in terms of any chronic diseases, anything apart? What all we are thinking in terms of?
A chronic systemic illness itself can cause short stature with delayed puberty.
So what are those systemic illness which may not manifest overtly, but may just manifest with short stature, delayed puberty?
For example, renal tubular acidosis can be one of the conditions where there may be short stature with the delayed puberty. Then isolated short stature plus minus absence or presence of puberty might be in a case of familial discord if there is a severe familial discord at home. So they might present with short stature in such
that will be there. We will talk about those causes, but before that we have many more. Like I'm asking chronic diseases, what all chronic diseases you will like to rule out when you would be investigating such a patient?
Monosymptomatic celiac disease also might be a presentation here. They might not present with overt steatorrhea or other deficiencies.
So in our like when we think about in our mind to do a basic investigation of a chronic disease patient, like this chronic disease causing short stature, what all things come to our mind? In a like one flow, it comes to our mind. Anything with renal causes apart from whatever you
renal involvement, or we can look at the renal involvement, liver parameters, as well as the chronic complete blood count to see whether there is any other involvement in these patients.
Okay.
Other than chronic,
something which would have manifested, which could have other causes, not in this girl maybe, but something would have manifested before, anything to do with glucose, anything which can lead to short stature, delayed puberty.
Glycogen storage disorders itself can cause short stature with delayed puberty, especially type 1 can have these complaints, and they might not present with hypoglycemia because they might wake up at night to have frequent short meals. So they might not present with the typical hypoglycemic symptoms in these patients.
And chronic infections, any infections can be the cause here.
For example, if there is a history of tuberculosis.
So these all things should come to our mind whenever we are evaluating. Maybe we will try to rule those causes one by one, but these causes should be there at the back of our mind so that we don't miss anything, because many of times they have proteinuria and all these are causes, and chronic illnesses, especially tubercular infections in our country, are still common. So we need to see that. Yeah. Sorry, Dr. Abhilash.
Chronic worms in the stool. We have to look at the chronic worms.
Yes, we have patients. Absolutely. Yes. Chronic infections, worm infestations are very important in our country still. So always should be there. If we think of syndromic causes, we may always be right mostly, but we should not negate those other causes also. So those chronic infections should always be there. Yeah. Yeah, Harshita, yeah, you can go.
So now supplement your history with all this, ruling out one by one.
Yes, sir. There is no history of headache, nausea, vomiting, or double vision, and there is no history of recurrent abdominal pain, diarrhea, or steatorrhea. There is no history of dyspnea on exertion or recurrent respiratory tract infections or hospitalization for the same. There was no history of head injury in the past, no history of chemo or radiotherapy.
Worm infestations, recurrent worm infestations, or anything history did you take, or any recent weight loss or loss of appetite you have told, like worm infestations and all, did you ask proactively? Because sometimes we do still see these things in our setup. We are still seeing in spite of the awareness and everything, but we still see. So we should always be aware. Yeah.
So when she presented at the age of 16, she was diagnosed to have hypothyroidism and she was started on levothyroxine replacement. She does not remember the initial dose, but she remembers that at a follow-up visit 6 months later, she was told that the thyroid profile has normalized and she was asked to continue the dose. She has been compliant with the medicine. She takes it on empty stomach and gives a gap of 1 hour. And after starting the levothyroxine for 1 year, she was not on any other supplementations. She was just followed up. During this period, she did not notice any significant change in her height or development of secondary sexual characters. So she was at the age of approximately 17 years, she was started on estrogen replacement. She was on the same for approximately 1.5 years, after which
was
she had
it
a
oral, what form she was taking estrogens? Did you ask her anything about that?
Yes, ma'am. She was on oral estrogen, but she does not remember the formulation. But currently, she is on an OC pill containing ethinyl estradiol.
Okay.
So she had her first withdrawal bleed 1.5 years after starting estrogen, following which she was started on an OC pill containing ethinyl estradiol and levonorgestrel, which she has been taking regularly since the past 14 years with regular withdrawal bleeds. She says that after starting estrogen therapy, within the first year, she noticed breast development and started having her cycles after 1.5 years. And she has also noticed scanty axillary hair and some pubic hair.
Your history is over?
Yes, yes. So she does not have other comorbidities like diabetes or hypertension, and she does not have any. Currently, she does not have any dyspnea or chest pain on exertion, and there are no history of recurrent urinary tract infections, no history of fragility fracture.
Right. I had a discussion with the patient and the bystander. So there was some history at birth. Anything more you could get at birth?
She had a physiological jaundice for 2 days, sir, for which she was given phototherapy, but it was not prolonged jaundice, sir.
Okay. And regarding the birth weight or size, did they tell anything?
Yes, sir. The mother said that she felt the baby was smaller in size, but she did not know whether it was also whether it was documented similarly or not. The mother had a perception that the child was smaller in size at birth.
You will come to socioeconomic history probably later.
I'll finish off now, sir. She stays with her mother, who is the current earning member of the family, and she is presently not working, and she has 2 elder siblings who stay separately. Her father expired at the age of 6 months due to some, there was some poisoning and he passed away. So unnatural reasons.
When this child was 6 months old,
yes,
he passed away. Yeah.
Yes. And also, she does not feel very confident to move in the society, primarily because of her short stature. She also wants to know regarding her marriage prospects, and she's concerned about the same.
Okay. Will you ask regarding the height of her father?
Yes, sir. They gave an approximate height. I used that to calculate the mid-parental height.
Right. Actually, we shouldn't do that, but it can give you a rough idea only.
Yes,
okay.
sir. Yes,
So,
sir.
and regarding the height of their brothers, her brothers?
Yes, sir. That approximate height they have mentioned.
They are, in your views, are they short, tall, or?
They are not tall, sir. They are around, they said approximately around 170 to 175 centimeters.
Right. Okay. Oh, and anything from the family history you would like to add? Nothing.
No,
more.
sir.
Okay. No other person suffering from a similar illness?
No, sir.
So,
Anything, like you have any other history pending still, or you are
No,
coming to
ma'am.
diet history? Diet history and calcium intake history, would you be interested to tell us in this patient? And the residents can tell, is it important or not important, and where
There was a
it is
disturbance.
important.
Can you please repeat, ma'am?
I'm saying the diet history, did you take diet and calcium intake history and the sunlight exposure? Are these things important in this patient?
Yes, ma'am. It is important, but I did not take it.
So do you have a basic idea about how much is her protein intake and calcium approximately? No, that you have not taken. Because it's important. We need to
Ma'am, I
take the
think
calcium intake history and all, because these are all cases. Yeah. Sorry. Yeah.
I think we can direct them as questions to the
Yes,
postgraduates who are attending. So, Dr. Neeti, would you like to answer Madam's question regarding the dietary requirements of an adolescent and any special needs for her?
Sir, regarding calcium requirement, around 800 milligram per day is adequate for this age group, and protein will be around 1 gram per kg body weight.
Okay, considering her 30-year age now.
Yes.
Okay, yeah.
You are considering her age as today's age. Okay, fine. Now, okay. But will you be concerned about her bone health?
Yes, ma'am. Since patient is having delayed puberty, so there is a concern for the low bone mineral density in this patient. As we expect a peak bone mineral density to be achieved in Indians at around third decade. So, so it is important to look for that, as we are the first differential diagnosis Turner syndrome. So they are more predisposed to low bone mineral density.
Okay, fine. We'll discuss that because she has to finish the examination. Then we can, I think, discuss that. That is a major thing to be discussed. So we'll discuss it. Yeah, Harshita, you can go ahead.
Coming to examination, she's conscious, oriented, and cooperative. Her anthropometric measurements are her height is 137.5 centimeters with a height SDS of -4 on IAP growth chart. And on Turner's, her height SDS is falling between 25th to the 50th centile.
Can you just repeat that?
Yes, sir. Her height is 137.5 centimeters, sir. And on a Turner's chart, her SDS is between the 25th to the 50th centile, sir. And on a IAP growth chart, it is -4 SDS.
So what is the average shortness of patients with Turner syndrome?
Sir,
Yeah, Dr. Neeti, please.
sir, around 20 centimeter deficit can be there with respect to the normal population.
Okay, please.
Her weight is 43 kgs with a weight SDS of -1.2. Her BMI is 22.8. So mid-parental height is an approximate value calculated taking her father's height as 170. Her mother's height is 143.5 centimeters with an MPH of 152.5 centimeters. The SDS of which is -0.9. Her neck height is 8 centimeters and height neck ratio is 17.2 and her waist hip ratio is 0.9.
What's the importance of neck height ratio in Turner especially? Is it important?
Yeah.
In Turner's
yes, ma'am.
patients? Is it
Yes, ma'am.
more important? One of the residents can answer in the group.
Yeah,
Yeah.
Dr. Manjunath.
It is important Turner syndrome because if there is short neck and webbing of neck, they are predisposed for the cardiovascular abnormalities, more risk of cardiovascular abnormalities, like coarctation of aorta, Baker's diabetes fall.
Yeah, so neck height ratio for metabolic syndrome in Turner's, is it more associated with that? Is it a better marker? And are there any data in Turner's patients on neck height ratio and waist circumference being more important markers for prediction of metabolic syndrome?
Yes, ma'am.
There are studies for that as
risk
well.
for insulin resistance, high insulin resistance.
That's why neck height ratio is an important parameter in them actually. Yeah.
Okay, please. Come
Yeah, please, Harshita, please carry on, please.
Her upper segment to lower segment ratio is 1.14. She is having disproportionate short stature and her arm span is same as height. It is 137 centimeters. Moving on to vitals, she is currently afebrile with a pulse rate of 84 per minute, which is regular, normal.
So in anthropometry, would you like to add anything regarding the segmental lengths?
Yes, sir. Yes. I have measured her only upper limb segment, sir. I was not able to finish the lower limb. Her arm length is 24 centimeters and her forearm length was approximately around 18 centimeters with a significant difference suggestive of mesomelia.
Right.
Okay.
So you should have mentioned that in.
Yes, sir.
Yeah,
Right.
this is important. Yeah, this is a very important finding. This has to be mentioned.
Okay, ma'am. Her pulse is 84 per minute. It is regular, normal in volume. No rate.
Turners will have what? Tachycardia, bradycardia. Normally, what is more common?
Sinus tachycardia will be there.
Tachycardia. That's why something in ECG we see in Turners, which is very important, and that is why because of this tachycardia we use a different equation for calculating the QTC. Which equation we use for calculating the QTC?
Formula, I think we use.
Yeah, the reason for that is because that
Takes
takes
heart rate into
consideration.
consideration.
Yes, so because they have tachycardia, so we may get wrong with the may not get a very correct
QTC.
information with the, with the other formula. So that's why we use this. Yeah.
Blood pressure in the right arm is 100 by 50. The left arm is 94 by 52. The left leg is 110 systolic and the right leg is 108 systolic. And she does not have pallor icterus cyanosis clubbing, lymphadenopathy or pedal edema. And coming to head-to-toe examination, she has low set ears.
You have finished the skin totally?
Ma'am,
Skin.
I'll describe it in the head-to-toe exam.
Okay, fine. Take it.
Yes,
please go ahead.
She has low set ears, sir, and there is no hypertelorism, no ptosis, no epicanthal folds, no strabismus or no down slanting eyes, and she does not have micro or retrognathia. There is no high arched palate. There was overbite with malocclusion of the teeth.
Okay.
And she also
high arched palate in Turners is actually supposed to be an illusion. Actually, it is not high arched in Turners. It is just the thing is, anatomy is like that. It looks high arched, but actually it's supposed to be an illusion.
Yes, ma'am.
Right? Yeah. Please go ahead.
Sure. Yes, ma'am. She has short neck. There is no low posterior hairline or no webbing of the neck. There is no goiter, but acanthosis is present. And coming to upper limbs, she has bilateral cubitus valgus, and there is no mid-lung deformity or short fourth and fifth.
From the residents, tell us how do we diagnose cubitus valgus? How do we measure it?
Dr. Sandeep. Ma'am, can you please repeat the question?
Cubitus valgus, how do we measure it? What is the cutoff and how do we measure it? What is the
Cutoff is
ideal way
more 17 degree. If it is more than 17 degree, then we call it a cubitus valgus.
How do you measure that?
Is anything we have to measure?
Goniometer is used.
Have you seen? Have you seen that? Have you seen that?
No, sir, I have not seen.
It's okay. Yeah.
Okay. Dr. Harshita, you can tell. Yeah, you know that. No? Yeah.
So no mid-lung deformity, no short fourth or fifth metacarpals, and no edema of the dorsum of the hands or feet, and no nail hypoplasia. And coming to chest, there is no pectus excavatum or no kyphoscoliosis.
Kyphoscoliosis is there on exam. Okay, you didn't feel, but I thought
yes,
there is kyphoscoliosis. Yeah.
Okay, sir. And no multiple pigmented nevi.
Anything in the spine you would like to add here apart from kyphoscoliosis? Anything else would you like to see in this lady now? Now she is Turner's and she has, you are examining her bones. So anything else?
Ma'am, she might have osteoporosis. There might be some tenderness. So we might have to examine for spine tenderness if she has a silent vertebral fracture.
Right. And nevi, you said are not there, huh? No increase nevi in her?
No, ma'am, no.
Pigment, okay.
Yeah.
Sir, lower limbs, there is no short fourth metatarsal, and there are no stigmata of multiple pituitary hormone deficiencies like cleft lip, cleft palate, or bifid uvula, single central incisor, or hypertelorism. No markers are there. And her Tanner staging is she has B5, P4. There is no axillary here, sir. And systemic examination, cardiovascular system, no murmurs or ejection clicks heard. Respiratory system.
Could have started with no cardiomegaly or
yes.
With
Apex beat, where do you feel? Yeah, where is the apex beat? First thing you start with the inspection, palpation, and then you go ahead with the auscultation.
Yes, sir. Respiratory system, bilateral
So
normal
apex
vasectomy.
is normal? Apex bit is normally situated in her?
Yes, ma'am. Apex is normal.
Normal. There's no cardiomegaly as per examination.
No, ma'am.
So is cardiomegaly or ventricular hypertrophy common in these patients, Dr. Rohit?
But if they have associated coarctation of aorta, they can have, ventricular
So
hypertrophy.
if they don't have coarctation, will they have it?
They can have.
Even in the absence of coarctation or hypertension, they can have enlarged left ventricles. Yes.
So anything anybody can tell, doctor can tell that about what happens, what are the cardiac defects you see in patients with Turner syndrome?
Dr. Rohit, please.
Bicuspid aortic valve, coarctation of aorta.
You can again divide it into congenital and acquired cardiac problems in a patient with Turner's. Yeah, please go ahead.
And they can have aortic dissection because of high
That's
blood
an
pressure.
acquired condition.
Acquired cause.
Okay.
That's an So anything more you would like to add on the aortic dissection? Anything else we measure in them?
Yeah.
Sir,
Any
aortic,
measurement is done which gives us an idea about which patient is more prone, which patient needs more frequent monitoring, which has a risk further of dissection.
aortic dilatation we can measure.
Yes.
So what?
Is
What is that thing which we calculate?
Aortic index.
Anybody else can answer?
Anybody can answer. Whosoever knows can answer.
We measure ASI. If it is more than 2 centimeter per meter square, it is a ratio of aortic diameter at the ascending aorta by body surface area.
Right.
If it is more than 2 centimeter per meter square, it is risk factor, and more than 2.5 is absolute indication for surgical correction.
Is there less than 16 years, more than 16 years, or it is the same for less than 16 and more than 16 years Turners? Are there different cutoffs or it's the same?
Dr.
I don't remember.
Ma'am, in less than 16 years, we look at the Z score of the patient and we look at certain sites like the aortic valve.
How much is that score? Z score is how much is that?
Z score of, I think it is 2. I'm not sure. I think it depends if it is if there is bicuspid hypertension present or not present. If that is, then less than 3 it is low risk, more than 3 it is high risk.
Okay. Then, so if the patient is above the age of 16 years and you don't have anything like ASI is less than 2, then you don't do anything. You just repeat every 5 to 10 years, right? But if the ASI is between 2 to 2.3, then what do you do? Patient has no other thing. So like no coarctation of aorta, no bicuspid aortic valve, other things. But the ASI is between 2 to 2.3. Then the patient is qualified as moderate risk, right? So then you repeat it, the transthoracic echo every 3 to 5 years, right? But if the patient already has coarctation of aorta, already has a bicuspid aortic valve, or the patient has hypertension and the ASI is less than equal to 2.3, then you classify the patient as moderate risk. And then you again have to do the transthoracic echocardiography every 2 to 3 years. But if the patient's ASI is more than 2.3 with coarctation and bicuspid aortic valve, then patient is classified as high risk. These are the patients who need more frequent monitoring every 6 months to 1 year. And anything connected with the pregnancy with this, like if suppose a woman is planning pregnancy and this ASI has any relation with that as well? Do you suggest for vaginal delivery? Do you suggest for a short second stage of labor? And do you suggest for like cesarean only?
Dr. Yashasvi, you want to answer?
Ma'am, in patients with history of like aortic dissection and all of that, we advise against pregnancy.
No, with this ASI, madam.
With ASI of 2.5, sir, we have to go for cesarean section. We avoid normal delivery. And also, ma'am, assisted to decrease the second stage of labor, to decrease the stress and decrease the risk of aortic dissection during delivery.
I think it's about 2 itself. We consider
yes.
Consider for cesarean section.
Correct. Because better, because otherwise you have to have a very short second stage of labor. Otherwise they run a high risk. So you have to be very proactive with the monitoring. Yeah, we can go ahead. Yeah, because we have many things to discuss.
You have completed?
Sir, CNS 8th cranial nerve examination. Her Weber's is not lateralized. Her Renes is negative in the right
So
ear.
you have left the higher mental functions.
No, sir. Her higher mental functions are normal. There is in the cranial nerves, the other cranial nerve examination is normal. 8th cranial nerve, Weber's is not lateralized, sir. Renes is negative in the right ear. Bone conduction is more than air conduction.
Okay.
And her absolute bone conduction is equal to mine.
Okay.
Motor and sensory system examination is normal, and no cerebellar signs. Skull and spine I thought were normal.
You think was normal. Okay, but you didn't mention it earlier. That you didn't mention about the spine.
I thought it was normal, so there was no kyphosis.
So in the cognition and all, do you want to add a little bit more? Did you try to ask a little bit further into that? What type of things are more like, what things are Turner syndrome patients stronger with, and what is weak in them as regards to the neuropsychological studies, or what are the cognitive abilities which have been checked in Turner's? So what is more better, little bit, what may be weaker? May not be 100%. Each patient, there may be different sets of patients, but mostly their verbal skills are better, right? And their non-verbal visuospatial abilities, they are weaker, right?
Yes, ma'am.
Calculations are
yes, sir, they are weaker. Executive functions are also affected.
Yes, yes. So that's also important. It's always good to ask, because later on, one of the things will be the patient, what will the patient doing, profession, all those things are also important. As a doctor, we have to see and advise them those things also. No? They should not go into a field where they may not be very successful. Sometimes they may ask what is the best for her. Then we may like to do a neuropsychological evaluation. A detailed evaluation can be done by a neuropsychologist. There are different neuropsychological tests which can be put, and then we can see what the patient is better in, whether some patients have very good verbal skills. They may be lacking in the visuospatial and all those things. So we need to see that. That's neuropsychological assessment is a very, very important part of Turner's assessment.
Yes, ma'am.
Dr. Aditya, how investigate this patient? So our differential diagnosis are: one is Turner syndrome, second is a systemic illness, and third is a multiple pituitary hormone deficiency. Malnutrition, then helminthic infections, etc. So how will you go about it?
So initially we'd like to do the baseline investigations, and followed by hormonal investigation, followed by imaging. Baseline investigation, we need to rule out any other systemic illnesses are there or not. The complete blood count, CBC, ESR, renal function test, liver function test, urine routine, especially to rule out RTA with the VBG.
Okay.
Then
protein for protein as well. Proteinuria also has to be seen, not only RTA. Because RTA, you might still need to do ammonium chloride loading and see, but that is okay. That you have to see. You have to also do a potassium. That may give you an indirect idea, but also urine we are doing for protein also to see for any proteinuria. Right? Yeah, please go ahead, please.
So for hormonal evaluation, if we have a high FSH, LH with low estradiol, it almost confirms it. And then
by what age will you expect a high FSH level?
So by childhood, it's around
3 years of age,
around 6-7 years of age.
Okay, probably after 7 or 8 you should find a mildly higher FSH level than the peers. But even in childhood, the levels are just above the normal children. Okay.
So the other hormonal tests would include thyroid function.
There are studies where they have tried to see the retrospective data of Turner's patients, and they have found that those patients had higher FSH levels even in their childhood times also. Higher normal, they may not be higher than normal, but they're high normal. So it has been seen, and there is a lot of data on that. They had done some retrospective analysis of 62 patients or something. Yeah, please go
Other hormonal tests include thyroid function test with an anti-TPO antibody. Then growth hormone IGF-1 is not required in this case. We'd like to do an ATM cortisol as well to rule out any combined pituitary hormone deficiencies. Then for confirmation karyotyping, then I'd like to go ahead with an ultrasound.
So how many cells, when you write for a karyotype, what will you write the instructions? How many cells? What is the minimum standard required?
What is the standard requirement of a karyotype? Number of cells?
Screening is 20 cell karyotype with G binding.
Is the one which we usually do. Okay.
For Turners, what do you normally mosaic and all you will have? No?
100 cell, for that 100 cell karyotype.
Suppose you are suspecting
Guideline,
Turners
yeah.
and still you are not getting even in a 100 cell karyotype. What else can you do?
We can do a fish or a chromosomal microarray.
Before that, any other tissue you can use?
We can use other tissues as well, like buccal mucosa.
Like?
Buccal mucosa.
Anything else?
Skin
fibroblasts
skin
or even
fibroblasts.
shredded bladder cells you can use. Yeah.
30 cells is what is required as per the guidelines. Isn't Dr. Harshita? For the karyotype, I think 30 cells is what is recommended as per the
Some
guidelines.
guidelines, I think 20 is also mentioned.
Some
30.
guidelines say 20, but with 30, they say that most of the mosaicism also they'll catch. So they say it is better to do 30 rather than 20 because with 20 we may miss mosaicism, and with 30 they say 95% times we will catch it. Still we may miss, then we have to do further testing.
Right.
So yeah, please carry on, please. Yeah.
So how many of these persons with Turner syndrome will have the usual XO?
Monosome.
Yeah.
Around 50% will have monosomes.
And how many of them will have a mosaicism?
Around 30% of them
Yeah.
have mosaicism.
The 25 and the rest 25 would be
Structural
structural abnormalities of the X chromosome. Right. So any chromosome which is now not classified as Turner's.
XQ abnormalities.
Yeah. The distal XQ abnormalities.
Distal SQ, yeah. So Harshita, now this patient has come. So one of the residents can answer. So what will, like, first this patient had come and you have diagnosed the patient as Turner's. Now what will you do at that point of time? What was the age of initial presentation?
16 years, ma'am. 15 to 16.
So patient has come around 15 and a half, 16. Now the patient has come to you. So what is your management plan now?
Ma'am, I'll just interrupt in between. We will stop in the next 7 minutes, ma'am.
Okay, fine. Sure.
Yeah. Please, Dr. Joel, please answer that.
Yeah.
Sir, we need to do the bone age.
What do you expect in Turners?
The bone age will be normal, ma'am. Normal.
But is that what we see, ma'am, usually? There can be some delay in
sometimes,
bone.
yeah. So when do you see, when will you be normal, when it will be delayed? Harshita, will you tell?
Ma'am, there was a disturbance, could not hear that.
Harshita, can you tell when will the bone age be normal and when it will be delayed?
Yes, ma'am. I mean, till puberty, the expected age of puberty, it generally goes normally along with chronological.
After that, we find it delayed. Absolutely. So when she has come, what are we expecting with the bone age at the age of 15 and a half?
There'll be a delay in the bone age, ma'am.
Right. So there is a delay in the bone age. We have got the bone age. Now we have to just discuss what are the treatment options because we have less time. So let us discuss the treatment options.
What are the ma'am regarding the investigations at the first visit?
I think treatment we can discuss because we have less time. So let us discuss the estrogens they are going to give. What is the difference between the transdermal and the oral? Which route is preferable in case we have everything? And then when do they add the progesterone? I think they can tell that, and growth hormone little bit.
Please.
Actually, transdermal estrogen is the preferred one since the oral estrogens are bound to have many side effects also.
Have any studies shown like that in Turner syndrome?
I'm not sure in Turner's particularly.
So what is the data regarding Turner syndrome, Dr. Abhivar?
What is the transdermal to start?
What's the transdermal estrogen you start?
What is the transdermal estrogen?
Ma'am, can you hear us, ma'am?
What is the dose? What dose you start?
What's the dose? Okay.
Transdermal, I'm not sure.
Okay, what's the dose of oral estrogen you start?
So we start with estradiol validate 0.25 mg and we gradually up titrate if it is a patient who's coming at around 13 to 14 years of age. So we will gradually up titrate every 3 to 6 months. And then we take it to a maximum dose of about 2 years. And then after that, we introduce progesterone, or if there is withdrawal bleeding, at that time we will add progesterone to that. Transdermal dose, I'm not sure.
Transdermal dose is usually 1/40 of the oral dose.
So you start at transdermal you start at around 3 to 7 micrograms per DL. And normally we don't have availability, like now in Bangalore, we are getting transdermal estrogens, but the problem is that it is available as a patch of 25, so we have to give 3 to 7. So if you see the package insert, it says, no, you can't cut the patch, but what the studies have been done, what they have recommended is we can use 1/4 of the patch. In the night, they can apply, and with 1/4 of the patch can be used, and then we can use that way. But though the package insert says no for that, but the dose to start is 3 to 7 micrograms is what we start, micrograms per DL is what we start. Then we go to 25 to 100 over a period of time for transdermal, because transdermal is the safest in case nowadays patients are affordable and they can afford actually. So we can use it. I think a little bit about growth hormone should we discuss, because we have less time.
How they will escalate and when they will add
Yes,
progesterone?
please.
Okay, when you will add progesterone?
I just mentioned that, sir. At the end of 2 years of after escalation of estrogen, we will add progesterone, or if there is withdrawal bleeding,
Okay,
at that time
fine.
we will add progesterone.
Now regarding at the age, suppose she had presented at 8 years of age. So how will you give growth hormone? Would you
Growth
consider
hormone has
that?
been seen to be, we can start growth hormone as young as 9 months of age, and after that, ideally we should start at a higher dose of 0.375 mg per kg per week, and we would start it if we see there is faltering of growth in the Turner specific growth chart, and after that we will start the growth hormone therapy in these patients, and
So now, what age you will, bone age you will stop the growth hormone? At what bone age, or what is the height velocity criteria to stop the growth hormone?
the height velocity of less than 2 centimeters per year, or the bone age of in women 14 years, or fusion of epiphyseal plates, we will stop growth hormone.
Okay, fine.
The age for initiation of estrogen you had mentioned?
12 years, sir.
11 to 12 years.
11 to 12, yeah.
So,
So anything else we can use apart from growth hormone? Anything else which has been used?
Zangulon 0.03 to 0.05 mg per kg.
Correct.
Yes, but what are the side effects?
Side effects are breast atrophy or
poor breast
development. Sorry, poor breast development.
And
virilization is slightly rare, but.
So
Okay,
what are the monitoring? Yeah, what are the monitoring you will do in a Turner's case? Sorry, Dr. Abhilash, please. So sorry.
Please, somebody else can answer. Dr. Niti. Ma'am, can this be the last question?
Yeah,
Because
one more thing we can ask, just one question is, which cancer is less in Turner's?
Breast cancer?
Yes. Yeah, please tell that the first question, monitoring.
Once the patient is on growth hormone therapy, we should follow up the patient by doing IGF-1. The target is to keep the IGF-1 between, the upper limit is +2 standard deviation. If it is more than that,
before IGF, just mention the clinical.
Yes, sir. So first need
growth
to
velocity is the one which
compliance of the therapy needs to be checked, the injection sites, and patient needs to be monitored for thyroid function test even after initiation of growth hormone therapy. Then other side effects of growth hormone therapy, like worsening of scoliosis or development of subcapital femoral epiphysis, and if there is any development of intracranial hypertension, this patient needs to be monitored for that. And then growth velocity needs to be monitored. If there is faltering of growth velocity, then other associated disease like celiac disease and coexisting hypothyroidism needs to be ruled out. And for regarding the safety of the growth hormone therapy, IGF-1 needs to be monitored. If it is more than +2 standard deviation, then we need to decrease the dose of the growth hormone.
More than 3 standard deviation, you have to decrease the dose. Between 2 and 3, you have to take a clinical dose.
Yes, sir. And if it is less than 2 standard deviation, then dose of the growth hormone therapy can be increased depending upon the height velocity. So we can go up to, as we initiate with a 50 microgram per kg per day, we can go up to a 67 microgram per kg per day. And then we'll monitor with IGF-1 levels.
Okay. Ma'am, can we?
Yeah, I think we are exceeding the time. Are we I think as like we can't exceed the time.
But I think for changeover, we need 2 to 3 minutes.
Yeah, sure. Thanks everyone. Thanks, Dr. Harshita. Thanks, Dr. Nair. Thanks all the residents. I really enjoyed it. Yeah.
Thank you, CMC, for this nice program and inviting us for this. Thank you.
Thank you very much. Can I have a big round of applause for our faculty and also for our 10 people who've stood the exam very well. And may I now request you to go back to your respective seats, and I request the next set of PGs, that is group D2, to please come in front. That would comprise of Dr. Abhirup Banerjee, Dr. Kaushal Seth, Dr. Varun, Dr. Rashmi, Dr. Nishchita, Dr. Gopal Datta, Sumanas Gopal Datta, Dr. Afsar Fatima, and Dr. Vishal.
Dr. Nikhil, good evening. I think Dr. Nitin will take over. Nitin?
Yes, sir. Yes, sir. Sir,
Are
can
we
you hear
audible?
us? Yes, sir. You're audible, sir. Can you hear us and see us, sir?
Yes.
Great. So we thank our next two senior professors, Professor Nikhil Tandon, Professor and Head of Department of Endocrine at AIIMS New Delhi, and Professor S.K. Singh, Professor and Head of Endocrine at IMS Banaras, who've joined us online. And our next case discussion is on Cushing's syndrome. I request Dr. Johns from CMC Vellore to come and present the case, and request the examiners to take over.
Good evening. So we will take through a challenging case of Cushing's, which we had to manage in the last 1 year at CMC. So the index presentation of this 47-year-old gentleman was in January of 2018. And he came to us with a history of gaining about 15 kilogram of weight over a period of 2 years, associated with diagnosis of hypertension. He had a 6-month history of EC bruising over the body, and he had also noticed multiple purplish abdominal striae. He also had difficulty in getting up from squatting position since the last 4 months, and an associated swelling of both feet since the past 2 months. They had also noticed an increased pigmentation of the nails of the hands and feet, also with an associated decrease in libido. He did not have headache or visual field defects. Recently, he was started on 3 antihypertensive medications for lowering his blood pressure. His blood glucose levels, as checked outside, was normal, and he was not having a history of exposure to Ayurvedic or alternative medication use, and there was no history to suggest fragility fractures. On examination, his height was 166 centimeter with a weight of 90 kilogram and had a BMI of 32.1 kilogram per meter square, which is a class 2 obesity according to the Asia Pacific grading. He had a waist circumference of 99 centimeter. His blood pressure was 140 by 80 millimeters of mercury, and he was noted to have bilateral pitting pedal edema. So this is the clinical photograph of the person. On examination, we found that he was having roundening of the face with associated facial plethora. He had multiple skin bruising. We can see one bruise on the right lower leg of this gentleman. He had multiple non-tapering striae, which is more than 1 centimeter over the abdomen, with associated hyperpigmentation over the knuckles and the elbow. He did not have goiter or other features of insulin resistance. The systemic examination was unremarkable except for having a proximal myopathy with bilateral hip joint power of 4/5. So
Right. So let me just ask you a couple of very quick questions, and before you go through your provisional diagnosis, why do you think there was so much pedal edema? I mean, it's not a consistent finding in Cushing's. So what could be the factors which were responsible? And secondly, what do you think were the factors responsible for the decline in libido? And thirdly, he had significant blood pressure effects needing 3 antihypertensives, but no glycemic effects because the person, as per your history, had no diabetes. So what can explain concordance between these two effects, and what will happen, which situations are consistent with a discordance between? So these are my 3 questions at this point in time.
Coming to pedal edema in Cushing syndrome is not a very common finding, as it is seen in only about 20% of patients. And the reason for that is because there is a decrease in the ADH level and also a resistance at the renal tubular level in normally when there is hypercortisolemia. But in certain group of individuals, they can have the pedal edema could be explained by the excess mineralocorticoid activity, which is itself resulting in the fluid retention. So it could still be noted in about 20%, but not in every person.
Even, John, even if there is an increased mineralocorticoid activity, still they may not have edema. Any explanation for that? We don't see edema universally, and we see most of the patients having increased mineralocorticoid activity. So still they don't have edema. How do we explain that?
Let me just add to that, is that traditionally, primary hyperaldosteronism does not have edema, right?
Yes.
Number one. Number two, does the presence of, even if you're saying it's mineralocorticoid excess, does it give you a hint towards disease etiology also? Is that something you'd like to answer? I'm not so sorry. I'm not exactly sure when other people are supposed to jump in, but feel free to jump in whenever you want. But going back, so the edema and mineralocorticoids, how many cons will you see we've got edema?
Yes, it is classically described as hypertension without edema. So it is not seen.
So why would you want to invoke mineralocorticoid excess as a high up in your list of contributing factors? Think of some others, or somebody else can also think. So your ADH story is all right. What else? What antihypertensives was he on?
When he initially presented to us, he was on telmisartan, and he was also on cilnidipine. And the third antihypertensive was a beta blocker.
So cilnidipine is not traditionally associated with significant edema. Anything else which can be contributing to the edema? In addition to what you've said?
Because all Cushing's patients, they can have a underlying infection. So any associated hypoalbuminemia, which is going on in the setting of a chronic hypercortisolemia, that could also contribute to the edema, which could manifest.
If the edema was significantly asymmetrical, would that look at some other etiologies?
Yes, because Cushing's is thought to be a procoagulant state, and there is a higher probability of them having a deep vein thrombosis that can explain asymmetrical edema. And also if there is a coexistent infection like cellulitis, which is going on, that can also explain edema, which is confined to a single limb. And coming back to the edema, possibly if the hypertension was significant enough to cause a renal dysfunction or associated cardiac dysfunction, those can also explain the edema which is present in him.
Okay. Anybody else wants to add any other possible causes? Low down in the list, definitely, but anything else? If not, we can jump to the libido story. Why a reduction in libido?
In Cushing's disease, they can have a associated hypogonadism, and about 20% may have an increase in their prolactin level, both of which can explain the decrease in libido in a person with Cushing's.
And what is the mechanism of hypogonadism? What is the mechanism of hyperprolactinemia?
The mechanism of hypogonadism, because of the increase in the ACTH level, which is stimulating the adrenal androgen production, they can have a negative feedback inhibition at the level of the hypothalamus or pituitary, which could be the reason. But I'm not sure, sir.
And why the hyperprolactinemia?
The prolactin level could be increased either part of an associated insulin resistance in and also in women if they have an associated polycystic ovarian disease as part of their secondary PCOD can also explain the high prolactin level, or it could also be related to a stalk effect if you're dealing with a pituitary macroadenoma.
Macroadenoma is extremely rare, right? So that's very unlikely. Anything else? Anybody else would like to contribute? Okay.
Anyone can explain why there is a hypogonadism in Cushing? Any other in the audience? Yes.
So cortisol directly suppresses the HPG axis. Because of insulin resistance, there can be polycystic ovarian syndrome and decrease in SHBG as well.
Yeah, so GnRH pulse is blunted when there is hypercortisolism other than the ovarian or adrenal overproduction of androgen. Right. One question, did you ask about the height loss? You said that the height was something, I don't remember, maybe 160 or something. But did you ask about the height loss?
The height loss was mentioned, and that was a reason why we included about any fragility fractures. I also wanted to look at the height loss, which could be explained by incident vertebral fractures, which can happen in people with long-standing cortisol excess.
Is there a differential prevalence of vertebral fractures in women with Cushing's and men with Cushing's at equivalent ages?
Sir, can you repeat the question, please?
Is there a difference in the prevalence of vertebral fractures? Sorry, in difference in prevalence in vertebral fractures and between men and women with Cushing's?
So the bone-related changes are thought to be less frequent if there is a associated hyperandrogenemia, which is present in the person. So I think if there is an increased adrenal androgen production, then it could turn out to be protective for the bone. But the real difference between the gender, I'm not sure.
Right. So can we proceed further? So your provisional was, what was your provisional diagnosis in this case?
The provisional diagnosis was a 47-year-old gentleman who was coming to us with history of weight gain associated with hypertension, which is controlled with only 3 antihypertensive medications. On examination, he had discriminatory features, including proximal myopathy. He had striae, he had facial plethora, and he was having multiple bruising over the body. And he had an associated hyperpigmentation. We are dealing with the ACTH-dependent Cushing's syndrome. And coming to the etiology of the ACTH-dependent Cushing's, considering that this was a slow progressing process over a period of about 2 years, and his age of onset, I would like to consider both ectopic or pituitary, but pituitary would be considered more likely because that is commoner of both. I would like to, however, confirm with the further set of investigations.
On the basis of the clinical presentation, can you give more weightage to eutopic ACTH Cushing or ectopic ACTH Cushing?
In this gentleman, I would be thinking more of utopic ACTH production because of the age at presentation. Even though male gender may be associated with an ectopic ACTH production, that is usually in a relatively younger person, but he is already 47 years of age. And the duration of symptoms in ectopic, other than the indolent bronchial carcinoids, it is usually an acute onset of presentation. And the weight gain, which is also more a prominent feature in Cushing's disease than a malignant ectopic process. All this will most likely point towards a utopic source of ACTH excess. But at the same time, the other proximal myopathy was present, but it was not very prominent. I would like to confirm with other biochemical parameters, including the extent of hypokalemia or alkalosis, to further substantiate whether it was an ectopic or a utopic ACTH producing tumor.
So I have a general question. What is your understanding of, pre-test probability in trying to interpret any test? What is your understanding of the concept of a positive likelihood ratio or a negative likelihood ratio? Because tests have to be interpreted in the context of the clinical scenario and should not be, just done for the sake of doing them in a general population, right? So what are your thoughts on these two issues? Pre-test probability and a likelihood ratio, either a positive or a negative likelihood ratio, whatever you want to explain.
So pre-test probability, even before we order a particular test, what is the probability of that test helping us in identifying a clinical diagnosis or helping in confirming a clinical diagnosis which we already have? So that is what I understand by pretest probability, because when we are thinking of evaluating Cushing's syndrome in a person, and we have a gentleman who's already having discriminatory features of Cushing's, the probability of us arriving at a diagnosis, including an increase in ACTH or an increase in cortisol, would be much higher compared to another person of the same age. We are evaluating only for an obesity associated with increased blood glucose concentration. The probability of us picking up the diagnosis of Cushing's in that person would be definitely lower. So this is my understanding.
What about likelihood ratio?
The positive likelihood ratio, and when we are finding a positive test in a person, and what proportion of that it is actually associated with the disease.
Okay, and how would you calculate a positive likelihood ratio?
This will be the total number of patients who have actually tested positive based on our study. That would be the denominator. And the numerator would be the actual people with the disease.
So in reality, the likelihood ratio of a positive test result would be really a true positivity rate versus divided by the false positivity rate. So which is the same as sensitivity divided by 1 minus specificity, right? So that's the likelihood ratio of a positive test result in the context that you are working on. But anyway, you can read that up. It's important because, as you rightly said, you need to know the clinical context, the demographics, the phenotypic picture that you've painted before you are doing a test, because only then can you be certain that how appropriate it is to interpret a test result. I'm going to flip your case around. So let's say it's a male, which this gentleman was, who has a very short history, presents with hyperpigmentation and hypokalemia, right? Dr. Singh asked you a question in your case, and you rightly said that you would consider utopic ACTH excess as a much higher probability than an ectopic ACTH. Right? In the scenario which I have now given, Male, same age, extremely short history, 6 months, hyperpigmentation, spontaneous hypokalemia. Would you now change your rank order of eutopic versus ectopic?
Yes, sir. The degree of ACTH production from an ectopic source is thought to be higher, and the usual values of about 90 picogram per ml is usually associated with an ectopic, even though there could be an overlap. So because of the increased ACTH, the hyperpigmentation and the increase in the glucocorticoid level, also the production of other mineralocorticoid precursors, including deoxycorticosterone, would be much higher in a ectopic source of ACTH, and hence in this clinical scenario, I would then consider ectopic as a more probability.
My question is going to be slightly different. You do an MRI in scenario 1, which is your case, and in scenario 2, which is the medical case which you have done. In both instances, it shows a 3 to 4 millimeter pituitary adenoma. How will you handle that?
So a pituitary adenoma of less than 6 millimeter, it could be an incidentaloma. So even if I am convinced that the person is having a eutopic or an ectopic source of ACTH and find a pituitary adenoma, which is only about 3 to 4 millimeter, before making a further conclusion that the adenoma is the reason for the cortisol excess in him, I would definitely like to proceed with other confirmatory testing and only then consider pituitary surgery as my treatment option.
And if I turn around and say that I would actually ignore that pituitary adenoma in a person who's a male who's got a 3 to 6 months history with spontaneous hypokalemia and proximal muscle weakness, and I won't ignore it in the first scenario, how would you respond to that?
So definitely in a short duration history, because we are thinking clinically about ectopic source of ACTH, I would definitely not consider the pituitary adenoma of about 3 millimeter significant in him, and would definitely look for another source of ectopic production of ACTH.
Right.
But coming to the first,
but the test is the same, an MRI. It's showing the same result, but you will end up interpreting that result very differently in these two scenarios because your clinical context is very different. Please understand, if you use only cutoffs and numbers in Cushing's and ignore common sense, you are much more likely to fail than succeed. It is not, it is a very, very difficult disorder. So please, you obviously do your test, but do not be obsessed with numbers, cut points, and thresholds unless and until you look at it in the clinical context. And that is very important for you to understand. I think we're running really late. I'm sorry if I've intruded. Maybe you should just go ahead. Dr. Singh, anything more at this point?
We should go ahead. Time constraints. Yeah.
So the second part of it was how to evaluate and confirm the diagnosis, so that I will come through the investigation results. He had a hemoglobin of 15 gram per deciliter, and his potassium levels were normal, 3.9 millimole per liter. Bicarbonate was 26, calcium, creatinine were normal. HbA1c was in the pre-diabetic range. The total cholesterol level was increased, associated with an increase in the LDL cholesterol. And coming to
just John, what is your take on why hemoglobin is 15? Do you consider this as something is a common thing to occur in
the hemoglobin level?
Yeah.
The cortisol level is thought to have a positive effect on the erythropoiesis. So finding a hemoglobin of 15 could be normal in this scenario, unless
is it the effect of cortisol on the homeopatin, or
they can have a associated the androgen excess that can also stimulate erythropoiesis.
It is the androgen axis. Okay. Yeah.
Coming to the biochemical assessment of his hypercortisolemia, we found the 8 AM cortisol was 26.6 microgram per deciliter. And the purpose of doing this was to rule out concomitant or rule out exogenous Cushing syndrome. And once that was ruled out, we proceeded with the midnight serum cortisol sampling and following that overnight DEXA suppression test. The midnight cortisol level was 18.5. This was a sleeping sample, and a cutoff of more than 1.8 microgram per deciliter confirmed that he had a interruption with the normal diurnal cortisol rhythm. And the overnight dexamethasone suppression test, his serum cortisol level was 17.2 microgram per deciliter, which is again indicating an unsuppressed hypercortisolemia. The baseline cortisol.
Can you describe the exact procedure for doing a midnight serum cortisol sampling? The exact procedure.
The procedure what we follow is to admit the patient at least 24 to 48 hours prior to the blood sampling, and we insert a IV cannula, and usually it is flushed with heparin so that there is minimal interference when we are collecting the blood sample. And the sampling is done between midnight 11 p.m. to 12 a.m. And it is considered to be a sleeping sample if the sample collection was done within 5 to 10 minutes of the patient being woken up.
And when you draw the sample, how much do you discard? It's a hep-lock cannula, right?
Yes, sir. It is a cannula which is flushed with heparin.
So obviously, when you draw it out, the initial component will have a dilution factor also. So how much will you withdraw and discard before you take the actual sample for the cortisol measurement?
So here we are initially, the initial 2 ml we are not accounting for, and then getting the next 2 ml, but I couldn't find a reference for that in the guidelines. They have only mentioned about undisturbed sample and preferable to collect after at least 24 hours of hospitalization, but we are discarding that initial 2 ml.
Do you really need to discard?
So
or can you put it back in? So take one syringe, withdraw, take the other syringe, use the sample and put the 2 ml back. Why do you want to discard? I'm asking you.
So that dilution factor still could be possible. I'm not sure about the answers.
No. I mean, you're taking 2 ml and discarding, then you're taking a fresh sample and then measuring it. So I'm just saying use a second syringe. First syringe, you draw 2 ml. Second syringe, you draw a sample and then put that back, especially in the ICU if you're going to do, not for this particular person, in the ICU if you're going to do multiple sampling and each time you're going to throw away 2 ml, you'll be responsible for anemia in the patient before you do anything else good for the patient, right? Chalo, aage chalo.
So the urine 24-hour cortisol collection, the basal sample was 1,215 microgram per day. And here we are taking a cutoff of at least 4 times than the upper limit of our lab threshold, which is 100 microgram per day. So this was definitely elevated. And the morning cortisol level was 67.1 picogram per ml with a midnight ACTH of 71. So a midnight sampling of above 7.5 picogram per ml, again based on a study from KEM, is also considered to be indicator of increased or ACTH dependent cortisol excess. So the initial biochemistry confirmed that patient is having a endogenous hypercortisolemia, which was ACTH dependent. And on assessment of the other...
First, if you look at the finding in the first row, don't you think that this is enough to suggest that this is a case of ACTH dependent hypercortisolism? Or you still feel that there could be some caveats and therefore you should go for other test?
Sir, at this point in time, there is no doubt about hypercortisolemia, and the 8 AM cortisol level was 67.1, and in about 50% of patients with Cushing's disease, the ACTH level will still be within the normal range of the lab. So, and
the urinary-free cortisol?
The urine-free cortisol level, it was 1,215. So about 3 to 4 times the upper limit of normal will indicate hypercortisolemia, but the role of that in confirming whether it is ectopic versus, there are certain cases of adrenal Cushing's in which they can have an inappropriately low level of urine-free cortisol, including the primary pigmented nodular adrenal disease, and also in possibly cases of ACTH independent macronodular adrenal hyperplasia, the urine-free cortisol levels are usually disproportionately lower compared to that other serum cortisol levels, and hence that could be a pointer that we are dealing with the ACTH dependent Cushing's.
So by doing the ONDST, did you further improve the yield of diagnosis in this case?
ONDST did not increase the yield of diagnosis, but our convention in our institute is to do all the 3 screening tests for Cushing's, and that is definitely done, especially when we are planning for a surgical intervention and also in assessing remission postoperatively. So the standard convention followed in our institute is to do all the 3 screening tests and then proceed with the further testing. So coming to the assessment of the other pituitary axes, we found that his testosterone level was 114 nanogram per ml and with a LH of 3.79 and FSH of 4.5. And this was indicative of a hypogonadotrophic hypogonadism, and which was clinically also evident. The DEXA in a scanning showed that at the lumbar spine, he had a Z-score of minus 2.0. And this was below the expected range for age for his age and gender. Subsequently, as the protocol followed in our institute, we proceeded with the MRI brain, and that MRI brain showed that he was having a lesion which was there on the left side of the pituitary. This is a T1 weighted gadolinium enhanced coronal section of the pituitary, and it showed a hypo enhancing lesion on the left side of the pituitary, and this was thought to be the reason for his hypercortisolemia.
What was the size of this lesion?
So the initial lesion described was a 0.9 into 0.8 centimeter lesion, which was on the left side. So, and taking into account also his clinical presentation, we considered this could be the possible reason for his Cushing's syndrome, and hence we proceeded with the further management. So the final diagnosis at this point in time is a 47-year-old gentleman with clinical features, multiple discriminatory features suggestive of Cushing's syndrome, and with biochemical parameters which are pointing towards ACTH dependent Cushing's syndrome, and an MRI suggestive of a pituitary microadenoma. The final diagnosis is that of Cushing's disease secondary to a pituitary microadenoma.
Okay, let's go ahead.
So he underwent a transnasal transsphenoidal surgery on 14th of February 2018. His post-op course was not complicated with a CSF leak. Histopathology showed a corticotroph adenoma with a MIP1 index of 4%. On postoperative day 3, he had symptoms of hypocortisolemia with nausea and vomiting. So we had taken a sample for serum cortisol, and we started him on replacement with glucocorticoids. The result came as 2.6 microgram per deciliter, which according to the current criteria, only a value of less than 2 microgram per deciliter indicates complete remission. Whereas in presence of symptoms of hypocortisolemia, a value between 2 to 5 could still indicate a partial remission. So the decision made at this point was to reassess the cortisol axis during his first visit, which we scheduled for after 3 months.
Okay.
So he came to us after 3 months in May of 2018. he did not have significant weight loss following the surgery, even though there was an improvement in his blood pressure and the requirement of antihypertensive medication had come down to a single drug. So we stopped the prednisolone and we reassessed his cortisol axis. We found that the ATM cortisol was 11.7 microgram per deciliter with a urine-free cortisol of 281 and an ACTH of 32.9. So because the HPA axis had recovered, our next target was to assess for the remission, and we proceeded with a 1 mg overnight DEXA suppression testing, and it came as 2.3 microgram per deciliter. And this was suggestive of a tumor recurrence or him not achieving remission. So we then advised for MRI brain, which was, however, refused by the patient.
So why don't we get some of the others in out here? Maybe there's a list provided to us, and I'll just go down the list. Maybe Dr. Singh can also do the same. So Abhiroop, starting with you. You know, in the old days when Dr. Singh and I were trainees, we used to do these tests, and we used to use a 5 microgram per deciliter cutoff, right? That was revised to a 1.8 microgram per deciliter cutoff. Why did that happen? What is the difference? Was it a change in the assay? Was it a change in the reality? Why was this change? And how would you like to interpret a 2.3 micrograms per deciliter in this particular patient? Abhiroop, you want to jump in out here?
So actually, when we consider the cutoff 1.8 microgram per DL, actually it indicates that possibility of Cushing syndrome. And if it is between 1.8 to 5, actually we diagnose few patients with Cushing syndrome, which the patient actually doesn't have. And that's why we reduce the cutoff to 1.8, although the cardiovascular risk already increased in patients with minimal cortisol excess of ONDST value of more than 1.8. And coming to these patients, sir, the first change which postoperatively predicts the recurrence of the disease, actually, sir, we have to look for the loss of diurnal variation. This is the first change to occur. And second thing, sir, thereafter we should look for the urinary free cortisol. And ONDST actually, sir, can be fallacious when the cortisol level is not that high initially post-operative period. So first thing,
do you have data? Do you have data to suggest a non-intervened ONDST versus a post-operative DST perform differently?
No, sir. ONDST can be done, but first change, actually that guideline has mentioned that the first change is we can get that first change.
My question is very different. Again, please understand, performance of tests is what is critical in endocrinology, right? So does the test perform differently in a non-intervened and an intervened individual?
Sir, I don't know the data.
Because you said that you were uncomfortable with the use of an ONDST 3 months post-surgery, and that your preference would have been a midnight cortisol, or sorry, a diurnal rhythm and a midnight cortisol, if I heard you correctly. Yes, are you concerned because of performance, or there is, in the natural history of Cushing's, that is how it really happens? So the first test to go abnormal is a midnight cortisol or a diurnal rhythm?
Yes, sir. There is the natural history of Cushing. The first thing we can.
Where is that reported? Do we have a cohort of people who didn't have Cushing's, and then you could measure these in evolution and you could show the natural history?
No, sir, no. Okay. I don't know about that.
So coming back to my original question, why was it reduced from 5 to 1.8?
Sir, actually, that 1.8, if the cutoff is 5, sir.
It's a screening test, right? You want it to be more sensitive.
Yes, sir.
But less specific.
Sir, in between, if it is 5, sir, then we'll actually rule out few patients with Cushing disease, which actually have Cushing disease, sir.
So you're reducing sensitivity by yanking up the cut point, but was there any change in assay? Was there any change in?
Sir, initially those cutoffs are possibly based on, sir, immunometric assays, sir. I don't know about the LCMS.
Okay. No. Nobody is doing LCMS on a routine basis here in any case, but yeah. Okay. Go ahead.
He subsequently came to us 7 months after the pituitary surgery in September of 2018. By this time, his antihypertensive requirement had gone back to 3 medications, with still having a blood pressure of 140 by 80 millimeters of mercury. His weight was 88 kilogram. The serum electrolytes were normal. The glycemic control from a A1C of 5.8% pre-operatively, it had increased to 6.2%. And at this point, according to the protocol which we follow, we again reassessed his cortisol axis, and the overnight suppressed cortisol level from 2.3 at 3 months had increased to 15.4 microgram per deciliter at 7-month follow-up. Because these features were suggestive of a tumor recurrence, we proceeded with a repeat imaging, and as seen in this picture, both the plain and the gadolinium enhanced T1 weighted coronal pituitary images, we could see that at the same location as the initial, there was a residual lesion which was present.
So before you tell us what is done, let's ask somebody in the audience to tell us what they would do. So on my list, Kaushal is the next person. You have a non-remitted Cushing's or a relapsed Cushing's, we don't know, with an MR evidence of a residual lesion. How do you show that that lesion is a residual lesion and is not post-operative changes? And if it is a residual lesion, what would you do now? We don't know what was done at CMC, but what would you do?
I would like to do again redo surgery, because lesion was at the same site as the previous one, and it is very clear and it is easily resectable. Whatever we could see from the image, it is a completely removable lesion, so a more chance of remission for this patient if we go for the redo surgery.
So if you look at case series of patients with Cushing's disease, what are the remission rates after the first surgery, and what are the remission rates if the person required a second surgery? Because the patient, if I was a patient, I'd ask you that, you know, last time also you said, I'll do an operation. We did the operation. I'm back again. Now again, you're going to say, do an operation. What are the chances that you're going to do anything good for me? Can you give me a guarantee? And is this surgery more or less likely to be successful than a first surgery with a visible lesion, right? If it was not a visible lesion, it's another story. How would you respond to that question by the patient?
We can't guarantee it, but we can go for more extensive surgery in the form of hemihypervisectomy.
So before you decide on what procedure you're going to do, what are the remission rates after the first surgery in a Cushing's disease? And if there's a relapse or a non-remitted patient, what are the remission rates for the second surgery? Anybody else, if you don't remember offhand?
In Indian series, it has ranged from 50 to 70%. One series from CMC 70 to 80, like that range was there. But most of the series.
First surgery, second surgery?
First surgery, sir. Second surgery data, I'm not sure. It might improve. Like,
just in continuation of the same.
Sorry.
What would be the predictive prediction of the remission or recurrence following the cortisol level in post-operative day less than 2, more than 2, or more than 10? So the cortisol level is less than 2. What do you think, that all of them will have a complete remission? If the level is more than 2, what would be the percentage of patients developing a remission, or what would be the chance of recurrence? And if it is more than 10, what would be the chance of remission?
With the level less than 2, the chance of long-term remission is more than 90%, sir. And more than 10, almost always patients will have, definitely will have relapse.
and
between
with the cutoff also slightly lower remission rate was mentioned.
So the remission you are quoting, that 70% or 80%, this was based on the post-op cortisol value of less than 2 or more than 2.
Yes.
Why it is like that? That even if it is more than 2, there is a possibility of remission in these patients.
Post-surgery, with the change in vascularity, the remaining corticotropes may still undergo necrosis over a period of time. So that's why we would like to assess at 3 months, again biochemically. And few patients may have remission at 3 months.
Okay.
Go ahead. Dr. Singh, we have about 15 minutes roughly.
Yeah. So we have that.
So in this gentleman, we proceeded with a second endoscopic transnasal transvenoidal surgery, and the lesion was occupying the same site as the initial surgery, and he did not have CSF leak. The histopath was suggesting a corticotroph adenoma with a MIP1 index of 6 to 8%. After the second surgery, he had a documented serum cortisol level of 1.2 microgram per deciliter on post-op day 2. And this indicated remission, hence was started on glucocorticoid replacement. Subsequently, however, he did not come to us for about 11 months following the second surgery, when he came back to us with further weight gains in the past 3 months, worsening of blood pressure, and a recent onset of diabetes mellitus. So the prednisolone was already stopped, and we reassessed his cortisol axis, which again showed that the ATM cortisol was 34 with the increased urine-free cortisol of 1417 microgram and the ACTH of 112. Again, the overnight DEXA suppression test indicated an unsuppressed cortisol of 24.3 microgram per deciliter. And the MRI was this time showing a less than 6 centimeter lesion, which was on the same side of the pituitary. So he had underwent biochemical remission after surgery, and now he has come back with further progression of his symptoms.
Okay. So should we get Varun to now come in here and tell us what he feels?
The options can be, we have to discuss with our neurosurgeon, and most radiotherapy will be more preferred option now.
So third surgery is an absolute no-no?
Not like that. Still can be done, but depending upon the lesion visibility and
lesion is visible. We had heard somebody mention hemihypophysectomy. Last time also an adenomectomy was done, and a successful adenomectomy because immediate post-op the cortisol had dropped. So is there any number of surgeries that you can do X number of surgeries, but you can't do X plus 1?
I think no, sir.
Okay. And then when you're saying radiotherapy, what sort of radiotherapy? Radiotherapy is a generic term. What are you really alluding to?
So options are axial beam radiotherapy or like stereotactic radiotherapy, depending here because it is a 5 mm lesion and away from optic asthma, we can consider if the patient is affordable, stereotactic radiotherapy can be considered.
So let's see, John, what's happening now next? What was done?
He underwent a stereotactic radiosurgery on 28th of November 2019 with a 20 gray exposure, and he was advised to review after 3 months for review. However, he did not come back for follow-up till in 2020.
So Rashmi, that's calling somebody back after 3 months is fine, but any radiotherapy procedure as opposed to a surgical procedure, when would you realistically expect to see numbers which tell you that there can be remission? Is it the response time to a radiotherapeutic procedure versus a surgical procedure?
Sir, compared to surgery, the effect of radiotherapy will be more.
will take time compared to surgery.
So if you're calling somebody back after 3 months, and I'm not saying you shouldn't, but what are you going to do? And if you don't find that the numbers have improved, does it mean it's a failed procedure, or are there other interpretations also? Remember, you'll be calling them, and if nothing has happened, do you feel that it's unsuccessful? Do you still need to do something? When is the cut point when you say that, we've given it enough time, nothing seems to be happening, we need to do still something more? So 3 months is the time when this person was called back. Your response to that? Obviously, the patient didn't come, but if the patient had come, what would you have done? And how would you have interpreted the results? Is there another slide of when just show us the next slide, John? When did he come back? Okay.
He came to us 19 months after the surgery, after the SRS.
Okay. And can you show us the numbers, the biochemistry at 19 months? Okay.
At 19 months, he was already started on ketoconazole from an outside center before coming to us. He was receiving 600 milligram per day. And on this is the biochemistry. He had a potassium of 3.4 millimole per liter. He had a metabolic alkalosis.
So, but the person who started him on ketoconazole, they must have done some test, right?
So that those values were not available with him. So this is the next review where we have documented a worsening of hypokalemia, metabolic alkalosis, as blood glucose levels had increased to 7.5% while on insulin. And this is the further biochemistry.
Okay, so I'm just saying that if his biochemistry was this at 19 months after or whatever time after that, versus 3 months after the stereotactic radiosurgery, would you interpret it the same way?
We will interpret differently, sir. The main reason for calling him back at 3 months was to reassess the other metabolic parameters. We are not expecting a decrease in his cortisol level within 3 months' time, but because he was already on.
So when would you really expect? Because again, I'm not, as I said, I'm not in any way contesting the need to call him after 3 months. I'm just asking, when can you categorically tell the patient it's worked, it's not worked?
So by about 2 years after the radiation.
It's about 2 years when you said, so whenever somebody hesitates and says about 2 years, I get worried. Somebody else, Nishtita? Patient will say, doc, tell me when can you tell me whether this, now you've done 2 surgeries, stereotactic radiosurgery, tell me when can you really tell me whether it's worked or not worked?
Usually around 18 months, sir. It takes time for response. Around 18 months, we can wait for the response.
Okay. Supposing at that time at 18 months, cortisol was, let's say 16, 17, UFC, what is your upper limit of normal? 100, you said.
100 microgram.
Let's say UFC was 300, right? ACTH was 32. How do you have decided? What would you have decided at that point in time?
Response is less likely, sir, even at 18 months, if the report is like that.
So you would intervene with more. So basically the issue is if it's either it's worked or it's not worked. If it's not worked, you have to do something more. Would you do something more at that point in time? And then if so, what?
We can go for a repeat dose of radiation.
And Nishita, what are the measures of response to radiotherapy? The measures of response. The biochemical response.
Yes, sir.
The biochemical response only, or any other measure of response?
Clinically also, sir.
No, obviously that goes with parallel to the biochemical response.
Even on MRI, if the size of the tumor.
Size of the tumor. So what do you think? There could be discordance between the change in the size of the tumor and biochemical response, or both are almost parallel in all cases of radio ablation of any endocrine tumor?
For radiotherapy difference, I'm not sure, sir.
Anyone can answer this? Yeah, are they parallel?
I'm not sure.
This is unusual. We may not have a parallel response. The tumor size response may be there, yet there may not be any biochemical response. So this discordance is there. You may have 90% tumor response, but only 50% biochemical response. Okay, so if there is a recurrence, you suggest that there could be another dose of ablation, radiofrequency ablation. Again, it can be done, or stereotactic surgery can be done.
If the options available is repeat radiation or medical therapy, sir. So we can consider repeat radiation or go for medical therapy.
Okay, what will decide the repeat radiation? Is recurrence is there, but does it a practice that all patients with recurrence following radiation can be subjected to radiation, or there has to be some points to discriminate that these are a sets of people, they cannot be subjected to a radiation again?
If any other associated pituitary hormone deficiencies are there.
No, the dose that will decide what doses they were used in the first
For
instance.
stereotactic around 18 to 20 gyri, sir. Conventional around 45 to 50 gyri. So if the cumulative dose of that much is all used, then we should go for medical therapy.
Okay. So let us see what they have done in this case.
So this is summarizing this gentleman who is now 50-year-old. He had 2 transnasal transphenoidal surgeries. He had a session of SRS, currently on medical management on ketoconazole, and he has severe Cushing's disease with 2 history of septicemia. So what we decided was the treatment options were discussed with the family, and considering that this was severe Cushing's disease with septicemia, which is a very severe form of hypercortisolemia, we decided to medically optimize him and then proceed with a bilateral adrenalectomy, which was done on 10th of August 2021. So we started him on mitotine 1 gram thrice daily, and also because the cortisol levels were not coming down on that, we started him, and because the infection risk was higher, the etomidate infusion was started in an ICU setting with monitoring of cortisol level. So this is a brief note about how to give an etomidate infusion and the monitoring what is required. What is important is that their Richmond agitation sedation scale has to be assessed, and BP and heart rate monitoring the cortisol level every 6th hourly with the metabolic panel. And it is preferable to give it in a ICU setup, 20 milligram being dissolved in 20 ml of dextrose. And once diluted, it has to be reconstituted. It has to be discarded in 24 hours time. We gave him a 5 milligram IV bolus. This was followed by an infusion, and we titrated the infusion rate to maintain a cortisol level between 10 to 20 microgram per deciliter. And this is the Richmond agitation score. So following the adrenalectomy, he had a long duration in ICU, required intense rehabilitation, and he was discharged after about 2 months from the initial day of hospitalization on prednisolone and fludarabine replacement, and he is planned for further follow-up.
Okay. The next person I can ask, maybe the penultimate question, Sumanas, when would you consider, we don't routinely use etomidate infusion prior to Cushing surgery. What are the sort of indications when you would feel obliged to do that? When you think it's important, and why?
So when patient is in psychosis or in any hypertensive encephalopathy because of hypercortisolemia or any psychosis, or he needs immediate control of hypercortisolemia prior to surgery. these are the times intermediates.
Okay.
Or patient is in, I mean, sepsis and Cushingoid. When antibiotic, I mean, patient is in sepsis and there's no good response to antibiotics. And
so why would sepsis be an indication for that?
Like psychosis and immediate control are the indications, sir, but
so if you don't have immediate control and the patient, the patient bilateral adrenalectomy, I'm just, right? You get immediate control the moment to the bilateral adrenalectomy. Is surgery going to be facilitated by the preoperative etomidate infusion? How does it make a difference with surgery? The best way of getting immediate control is by removing the adrenals, right?
yes, sir, but in a setting of severe hypercortisolemia, there will be more chance of thromboembolism post-surgery. And
post-surgery, the cortisol would have settled, right? Because you remove the adrenals. So is there a pre-surgical, so once you start etomidate infusion, do you have a cutoff? Do you monitor cortisol? You say once the cortisol reaches below this level, I'm going to take the patient off for surgery. How long can you give an etomidate infusion?
cortisol cutoff, I'm not sure, sir.
So how is it decided that, and maybe John should answer that because he may have more knowledge about this particular patient, that this now we're good to go for surgery, but we weren't good to go yesterday or day before yesterday? What?
So he had severe hypercortisolemia features clinically as well as biochemically. He was having persistent hypokalemia, and hence to decrease the cortisol level to the target range, which is about 10 to 20 microgram per deciliter, is our target while on etomidate infusion, and that is achieved by titrating the dose of etomidate and monitoring the cortisol level every 6th hourly. So we would usually continue this for about 3 to 5 days and maintain cortisol level within the target range before the patient is considered for bilateral adrenalectomy.
Dr. Singh, we have 1 minute. John, is there something game-changing you want to show us except for a recovered patient?
I'm waiting for.
Yeah, so this is about 6 months after surgery. He is with the operating surgeon, very happy, and so probably the decision to do the adrenalectomy was life-changing for him.
Only the last question. What about the risk of?
And this is the last what we have seen of him.
No, what about the future risk of having Nelson, developing Nelson in this case? Because it's still the adrenal residual, pituitary residual mass is there.
There is definitely a risk because for him, we were not able to re-image the pituitary prior to the adrenalectomy because he was not stable for that. And there is about a 25 to 40% risk of having Nelson syndrome, which is even higher when the person already has a pre-existent pituitary tumor prior to the adrenalectomy. So that is something which we have told him that has to be monitored regularly.
Fine.
Okay. Let me apologize to a couple of people who we couldn't reach out, but to ask questions. My fault. But I think in the interest of time, we should stop here. Maybe Nitin is already climbing up the stage as we speak.
Thank you very much, sir, for that very, very enriching experience. And I'm very glad to share with you, sir. We have over 75 endocrine trainees from all over the country listening to you in person in Vellore right now. And it was really a very, very enriching experience. Can we have a very big round of applause for this session? I thank our faculty, Professor Nikhil Tandon, sir, and Professor S.K. Singh, sir, for their immense knowledge sharing in a very dedicated, comprehensive way. And I thank all the participants, and I thank Dr. Johns for the presentation. Thank you very much, sir.
Okay, thank you.
Bye. Bye.
Bye-bye.
So with this, we move on to our next session for the day, and which is the first debate of our masterclass. And for this debate, I would just share the format of the debate as it would be, and as was informed before as well. We have in total 30 minutes for a debate. And in these 30 minutes, we will have the presentation for the person who will present for the motion first, followed by, and this would be for 8 minutes, followed by the presentation by the second debater against the motion for another 8 minutes. And the first speaker will get another 4 minutes to come back and have a rebuttal. The faculty who's chairing the session would get 10 minutes to summarize the entire session. We request everyone to please stick on time. Our first debate is on the topic denosumab versus bisphosphonates as a first-line therapy for treatment of osteoporosis. And I request Professor Nisha Bhavani, who's senior faculty from Amrita Institute of Medical Sciences, Kochi, to please come on stage. Our presenters for the two debates, Dr. Chetan and Dr. Siddhant, will speak for and against denosumab and bisphosphonates. And I would request Dr. Chetan to come on stage. I'd be privileged to chair the session with ma'am.
Good evening, everyone. So basically, the debate would be which drug should be the first-line treatment for bisphosphonates. Is it denosumab or bisphosphonates? So I shall be speaking for denosumab. So I have been given an opportunity to speak about denosumab. This is a drug which most of us in our day-to-day clinical practice, we have been rarely used it. But it carries many of the properties which should make it as a first-line drug for the treatment of osteoporosis. So I shall be enumerating them now. So denosumab is a fully human monoclonal antibody that inhibits the rank ligand. It was approved by the FDA and EMA in 2010 for the treatment of postmenopausal women with osteoporosis, and later it was approved in 2012 for treatment of osteoporosis in men. So mechanism of action, which most of us know. So the rank ligand is one of the mediators secreted by the osteoblast, which causes the activation of the osteoclast. So when the rank ligand inhibitors are given, like denosumab, this rank ligand is no more there to stimulate these osteoclasts. So the osteoclast formation, activity, and survival is inhibited, and that results in the apoptosis of the osteoclast. So coming on to the first point, the efficacy as a monotherapy, denosumab was tried in the FREEDOM trial. So in this trial, there was a significant reduction in the fracture incidence at the vertebral, about 68%, hip about 40%, and other non-vertebral sites about 20% as compared to the placebo. But the most important thing, or the most fascinating thing, happened when this trial was extended. So in this extension trial, the subjects were followed up for 10 years. So when they were followed up, the BMD at the lumbar spine and the total hip, it continued to increase for the entire duration of the therapy. And this was very unique character of this medicine, where all other classes of anti-resorptive drugs, they plateau after approximately 3 years of usage. This drug continued to give the benefit. So this is one of the drug which, this is a drug with unlimited benefit. Next, as comparing to the bisphosphonates, there are multiple trials and multiple meta-analysis were done to compare denosumab with bisphosphonates. In this trial called the DECIDE trial, the denosumab was compared with alendronate, and in this trial, on all the sites, that is a total hip, lumbar spine, femoral neck, and the trochanter, the BMD gain was more with denosumab compared to alendronate. The second trial was the STAND trial, which alendronate for 1 month, the subjects were randomized to either denosumab or they were continued with alendronate. So even in this study, there was a significant greater gains in BMD at all the skeletal sites, even after a transition after using alendronate. And in one more study wherein the denosumab was compared with the zoledronic acid, almost a similar effect was seen. So this was about the monotherapy, but how does it fare in as a combination therapy? So for this, I would like to quote the data study. Here, there were 3 groups of patients who were like, one of the group was treated with teriparatide, with denosumab, and the third with the combination. So as you can see here, in all the sites, there is lumbar spine, femoral neck, and the total hip, the BMD gain, the percentage change in the BMD was more with the combination treatment. One more thing what we can notice in this graph is that the BMD change in the femoral neck and the total hip, they were additive or supra-additive to the individual treatment with teriparatide or denosumab. And in this also, in this graph, we can see that it was not like the total gain was higher than the monotherapy, but also it was more rapid. So this denosumab teriparatide combination showed an additive or a supra-additive effects on BMD. There was a larger and a more rapid increase, and it also prevented the distal radial bone loss, which is the usual thing happens when teriparatide is used. And it not only increased the BMD, but also when it was evaluated by QCT, they also have seen that the microarchitecture also improved with this combination treatment. And the most probable explanation that they gave was that denosumab was able to fully block the pro-resorptive effect of teriparatide. And these effects were in contrast to bisphosphonate and teriparatide combination. Like there were many trials which were done using this bisphosphonate and teriparatide combination. Among them was the trial done by Black and et al., wherein parathyroid monotherapy, alendronate monotherapy was compared with the combination treatment. So at the lumbar spine, there was no difference in the BMD change with either of the 3. It was almost equal. However, in the total hip and the femoral neck, the gain with the parathyroid hormone was lesser as compared to the combination therapy or the alendronate. However, when these individuals were examined using the when their microarchitecture was analyzed, they found out that there was no much benefit of combining teriparatide with alendronate. So a combination of teriparatide and alendronate was a failure. So how does this medicine fare when it is given in the sequential therapy? So in the sequential therapy, this trial, the data switch study, like the subjects who were there in the data study were followed up, wherein one group who were there on teriparatide, they were transitioned to denosumab. The denosumab group was transitioned to teriparatide, and the combination was transitioned to the denosumab. So as we can see here, the green color graph and the blue color one, they were the group like where the teriparatide, they were transitioned to denosumab, or the combination was transitioned to the denosumab. So as we can see here clearly, there is an increase in BMD at the femoral neck, total hip, and the lumbar spine. So switching, and the gain that was seen in this study was greater than any of the sequential approaches. But as someone can notice, like the red line in all these graphs showed that like when the denosumab was transitioned to teriparatide, there was fall in the BMD, and also we all know that the fracture incidence also increases when such a type of transition is done. So do we have a solution for that? So this was answered in the frame extension trial. In the frame extension trial, like the subjects were given the 1 year of romosozumab followed by 2 years of denosumab, and later they were either given no treatment, or one group was given IV zoledronate, and the third group was treated with risedronate. So the first graph here shows the subjects who were not given any treatment after the denosumab. The second one was after giving IV zoledronate, and the third one is with risedronate. So in the zoledronate group, at the spine, there was 73% retention of the treatment benefit. And at the total hip also, there was a 87% retention of the treatment effect. So in contrast, those who did not receive any of the treatment, they lost about 80 to 90% of the BMD that was gained. And in the isotonic, there was an intermediate effect. So in IV bisphosphonates, after a short-term denosumab, retained the benefit which was gained after using a denosumab therapy. But and the effect also was augmented by delaying the therapy by 65 days. So
Time
it has
up.
to be
Just 15 more seconds.
Coming on to the dosing and administration, 60 milligrams subcutaneous is given once in 6 months, which is very comfortable for the patients. There is no need for fasting or any special instructions to be given to the patient, no need of IV administration, and also does not require any renal failure dose adjustment. Coming on to the side effects, it was initially thought that it could predispose to infections, but it was not seen in the freedom extension trial or the studies conducted by Stolina et al. And Decker et al. The atypical femoral fracture incidence was within the lower end of the range reported by the bisphosphonates, and the osteonecrosis of jaw is almost similar to what is seen with bisphosphonates. So it has got a good safety profile. So why should not this medicine be the first line therapy? It has to be at first line, since it has got a better efficacy as monotherapy, as a combination, as a sequential therapy. It does not have a drug holiday, and it has got an unlimited duration of usage, better safety profile, no need for dose adjustment in renal failure, and better health economics. Better health economics in the sense we know that this medicine is costlier, but however, when compared with bisphosphonates, where the compliance is compromised by the daily administration of the medicines, so the amount of fractures that it prevents and the effect on the health cost, so this should fare enough. So with the long-term vision is needed for any osteoporosis treatment, but with denosumab treatment, it should be more like proper selection of the patients and proper counseling of the patients before starting this medicine. I think this should fare very good. So this is like this old ad previously, like fill it, shut it, and forget it, was given for Hero Honda. So we can safely start this medicine. No dosage or adjustment is required in renal failure, and after that, it continues to give its benefit even after it is continued till 10 years. So this should be my
Thank you, Dr.
opinion.
Chetan. I invite Dr. Siddhant. A big round of applause for Dr. Chetan. We will invite you back for a rebuttal after Dr. Siddhant.
Good evening, everyone. My topic for the presentation is debate bisphosphonate versus denosumab as a first-line therapy, and I'll be speaking for bisphosphonate. Myself, Dr. Siddhant, second-year resident from PD Hinduja Hospital, Mumbai. What could be the better option than bisphosphonate, which is time-tested, efficacious, with minimum side effects, and which is cost-effective for the osteoporosis in Indian scenario? So bisphosphonates are the first anti-resorptive agents used for the treatment of osteoporosis. These are the carbon-substituted analogs of pyrophosphates. We have two groups of bisphosphonates, nitrogen-containing and non-nitrogen-containing bisphosphonates. So variety of options we have available, oral as well as IV. We have alendronate and rizetronate in oral form, and zoledronic acid in IV form, and ibandronate as well in oral as well as IV form. So my friend suggested that patient has to take pill every day. So we have options of zoledronic acid, which patient can take once a year. So just to look at the efficacy of the bisphosphonates, here's a study with the treatment with zoledronic acid versus placebo over a period of 3 years. Decrease the risk of morphometric vertebral fractures by 70%. We can see the incidence of morphometric vertebral fractures in 10.9% in placebo group and 3.3% in the treatment group at the end of 3 years. Again, the graphical representation showing the decreased incidence of hip fracture, non-vertebral fracture, and clinical vertebral fracture in the treatment group. The risk of hip fracture decreased by 41% in the treatment group. The study was conducted here in this esteemed institute, longitudinal changes in bone mineral density and trabecular bone score following yearly zoledronic acid. Again, it showed the increment in statistically significant increment in lumbar spine BMD at the end of first and second follow-up with yearly zoledronic acid group. So I would like to talk about the side effects of bisphosphonate. The most commonly we see about with the oral bisphosphonates is the esophagitis and GIT intolerance. However, the meta-analysis of 42 RCTs comparing GIT adverse effects with bisphosphonates and placebo clearly mentioned that there is no increase in the risk of severe GIT adverse effects in the bisphosphonate group, and we can lessen the incidence of minor side effects with the proper precautions. Atypical femur fractures, the absolute risk is very low, 3.2 to 50 cases per 1 lakh person years. And it is usually seen in patients who have received bisphosphonate for more than 7 years. And there are other contributing factors also like age, 65 to 84 years of age, glucocorticoid use more than 1 year, shorter height and higher weight. So recently published study in NEGM 2020 showing atypical femur fracture risk versus fragility fracture prevention with bisphosphonates, which clearly shows that the incidence of reduction in the fragility fracture clearly the benefit of reduction of fragility fracture prevention clearly outweighs the incidence of atypical femur fracture in the patients who have been treated with bisphosphonates. So we should not hesitate in using bisphosphonates in patient in thinking the risk of atypical femur fracture. Osteonecrosis of the jaw, again the risk of ONG is very low, 1 in 10,000 to 1 lakh patient years, and it is mostly seen in patients with cancer or immunocompromised patients, particularly patients with multiple myeloma or metastatic breast cancer who have received higher doses of IV bisphosphonates. And here again the other confounding factors are cancer and anti-cancer therapy, then patients with dental implants, glucocorticoid use, with a history of diabetes or smoking. So coming to advantages of bisphosphonates, we have variety of options available, oral as well as IV. My friend didn't talk about the fracture risk reduction in his presentation. He just talked about the BMD. We are not treating the report, we are treating the patient. So the fracture risk reduction is same as denosumab with the bisphosphonates, and it can be safely discontinued. There is no rebound worsening of the BMD. There is residual effect, and it can be used in patients who need denosumab discontinuation. So you have to come back to bisphosphonate even after using denosumab, and it is obviously pocket friendly. Comparing risk of osteoporotic fracture in denosumab versus alendronate treatment within 3 years of initiation. Here the graphs can show the incidence of hip fracture in denosumab cohort as well as alendronate. There is not much of a difference. It's a Danish nationwide study conducted over a period of 3 years. Hip fracture incidence was 3.7% in denosumab group versus 3.1% in bisphosphonate group, and any fracture incidence of 9% in each group. So there is similar risk of hip or any fracture in both the cohorts. Comparison of denosumab and bisphosphonates in patients with osteoporosis, another meta-analysis which identified 10 eligible trials. Here they mentioned that there is increase in denosumab, there is increase in BMD with denosumab as compared to bisphosphonates at 12 and 24 months of treatment. However, there was no difference in fracture endpoint at 12 months with denosumab, but bisphosphonate had a lower osteoporotic fracture incidence than alendronate at 24 months, which was shown in only one study amongst the 10 studies. Another meta-analysis identifying 11 trials, they again reinforced the same point that there is a change in total hip, femoral neck and lumbar spine BMD, which is more with denosumab than bisphosphonates. However, denosumab had no benefit for reducing the risk of fracture as compared to bisphosphonates, and no significant difference between denosumab and bisphosphonate in terms of adverse events. So coming to the denosumab disadvantages, there is a rapid bone loss after denosumab is stopped. We have seen a decline of BMD by 6.7% in first year after stopping denosumab. We cannot stop denosumab once it has been stopped, or we have to use some other agent to back up. And we have seen multiple vertebral fractures reported after denosumab has been stopped. In freedom extension trial, we have seen vertebral fracture rate increase from 1.2 to 7.1 per 100 patients years in the year after denosumab discontinuation. And we have to use some other agent if denosumab is to be discontinued. But denosumab use is particularly difficult in patients where loss to follow-up is more common. And we have seen in COVID times that even the patients who have delayed their denosumab shots by as short as 4 weeks, there is a decrease in BMD, which was gained with the earlier treatment. And again, the cost. So in Indian scenario, the cost is a major factor because denosumab cost at least 20 to 30,000 per year, and with bisphosphonate we can achieve the same things hardly with 2 to 3,000 per year, and so the patient compliance will be better with bisphosphonates.
Last 1 minute.
Thank you.
Great. Big round of applause.
So first, the point which was highlighted was that there is no change in the fracture incidence. But in all these trials, the duration of the follow-up was only for about 12 to 24 months or a maximum of 3 years, which was not sufficient to see whether how much of fracture incidence has reduced, because a drug which is causing a rise in the bone mineral density to such an extent, it should have an effect on the reducing the fracture incidence, but that will only be determined if the patients are or the subjects are being followed up for an extended period of time. And also the fracture also depends upon multiple other factors also play a role when a subject gets a fracture. So we cannot directly imply that the no change in the fracture is a negative point against the denosumab. And as a cost factor, yes, it is costlier, but when the health economics is studied and when we see like those individuals who are there on the oral bisphosphonates, like how much compliance we can expect from them with all the complications of esophageal irritations and with all that, we cannot tell how much of the people, how much individuals will be continuing the treatment. So ultimately, how much of protection it results, it's not sure. So when that is looked into, then the denosumab being the administration being very simple, like it is a subcutaneous administration given once in 6 months, I think it should have a better effect.
Thank you, Dr. Siddharth and Dr. Chetan, for that extensive elaboration of the advantages and disadvantages of denosumab and bisphosphonate. I think one point which you didn't mention is about denosumab is that it improves the cortical porosity, and the intracortical remodeling is better with denosumab. That is an advantage which denosumab has over bisphosphonate. And most of our bones are cortical bones compared to trabecular bones. So cortical bone density is better with denosumab compared to solindronate. So the mechanism of action of denosumab, this is because it is an immunogenic molecule. The side effects are more because it is directed towards the immune system, the dendritic cells, the T cells, everything has got rank ligand, and therefore when it is inhibited, the side effects are more. So there are molecules which are coming like oligonucleotides against the RAG ligands, which don't have this immune mediated things, and therefore the side effects may be less when compared to denosumab. So the concept is very good for denosumab in improving the cortical bone, reducing the thing, but the immune things and the long-term safety data we don't have. Solindronate is or bisphosphonate is a time-tested molecule. We have been, all of us have been using. Denosumab is probably definitely non-inferior to solindronate, but long-term effects, as Dr. Sri Siddharth has told, the side effects like the rebound decrease in bone density when it is being stopped, that is definitely a problem in the Indian context, because follow-up, many patients will be lost to follow-up, they will just disappear like anything. Therefore, the rebound decrease is a problem. Cost is definitely a problem for denosumab. Long-term follow-up is also a problem. So both have got, I think, advantages as well as disadvantages. Solindronate, especially renal failure patients, denosumab has got an advantage, but incidence of hypocalcemia is more in renal failure patients, 14 to 15% incidence of hypocalcemia is more. Then reproductive age group, maybe denosumab has got a better thing because it is not retained in the bone. It is the other thing, it will be long standing in the bone. So reproductive age group, maybe denosumab, we don't have studies looking into that. So both have got their own advantages and disadvantages, but in the Indian context, probably Solenronate is a time-tested drug. We need to give it only yearly. And we have data for 6 years for solenronate, and we need to have a drug to be followed after solenronate. And maybe we can switch to denosumab after that. After solenronate is what we practically do. The fracture data is set to come, as you said, long-term follow-up. The BMD data seems to be very good, but fracture data is on comparing these two, the fracture data is set to come. That is my take on it.
Thank you, ma'am. And I think very well summarized. Today, we talk of person-centered osteoporosis care. And when we have a patient in front of us, I think that debate has to be for that given patient, in that patient, whether denosumab is the better drug or bisphosphonates, given that patient's characteristics, whether that patient is going to come for follow-up regularly, whether that patient has a renal disease, and looking at all the other parameters, but very well summarized by ma'am. Can we have a show of hands as to who would vote for Dr. Chetan to win? Okay, around 10. So 10 people for denosumab and for Dr. Siddhant. So the hall is for Dr. Siddhant. A big round of applause for both the speakers. They did extremely well. And thank you for presenting both the points I think we learned together. So with this, I think, thank you, madam, for that summary and chairing this session. And we move on to the next session, which is another debate. And this debate is between Bombay versus Jodhpur. Right, so two different states, and I hope the faculty for this have joined. We are running a little ahead of schedule, 7:27. Yes, Dr. Sahu is here, sir. Can you hear us?
Yeah. Yes, Nitin.
Thank you. And so we welcome Professor J.P. Sahu, who is the professor and head of endocrinology at JIPMER, Pondicherry. And we also would like to wait for Dr. Nikhil Bhagwat, who would join from Bombay, Nair Medical College, to co-chair the session with Professor Sahu. So this debate is on calcium channel blockers versus alpha blockers in the preoperative preparation of pheochromocytoma. We have two eloquent speakers. We have Dr. Rohit Banbas from KEM Mumbai, competing with Dr. Prasoon from AIMS Jodhpur. So I think Dr. Nikhil is yet to join. We'll wait for a minute.
Nitin, shall I call, sir?
Dr. Thomas Paul is speaking to him right now on phone.
Fine.
So I think he will join shortly. So we'll follow the same pattern of debate. Dr. Rohit will present first for 8 minutes, followed by Dr. Prasoon for another 8 minutes, and then Dr. Rohit will come back for a rebuttal for 4 minutes, and then we'll request Dr. Sahu to summarize and suggest for the summary for the last 10 minutes. The total time of the debate would be 30 minutes. So maybe since Dr. Nikhil will join in 5 minutes, maybe we'll start. And I invite Dr. Rohit Banbas to present 4 calcium channel blockers. Over to you. We'll just wait for 2 more minutes.
Hello, good evening, sir.
Good evening, sir. Welcome. We are also privileged to have with us Professor Nikhil Bhagwat, who's Professor and Head of Endocrinology from Nayar Medical College, Bombay. So we will start the debate now. And first, Dr. Rohit will present the case in favor of calcium channel blockers.
Good evening, one and all. Today, I'll be speaking in favor of calcium channel blockers. I thank the organizer for giving me the opportunity to do this. So, alpha blockade is in vogue for the past 70 years. It was started in 1949. So now do we need to change our thinking? Calcium channel blockers in PPGL. So first patient, we have this patient, left-sided pheochromocytoma. It is a noradrenergic phenotype. Plasma-free norepinephrine is elevated. So this patient, as per the Endocrine Society guidelines, he was blocked with pre-op alpha blockade with salt and water as per the guidelines. He was well prepared for the surgery. Now this patient intra-op, look at his intra-op readings. There is persistent hypertension, which lasted for many minutes, causing STT changes. So what I want to tell you is this guideline, which says that all patients need alpha blockade, is based on very poor data. It's only on retrospective studies. When you see the hierarchy, it is very low down. And when you look at data on calcium channel blockers, the data is scarce. Our next patient, this is a adrenergic phenotype, a little different, plasma-free meta-secreting patient. So as we know that plasma-free epinephrine or metanephrine, adrenergic phenotype has additional beta-2 action, which causes vasodilatation. So this becomes very tricky to manage. So this patient, when we started her on very small dose of alpha blockade, 2.5, went on to 5, she required inotropic support. That was the profundity of the hypotension in this patient because of this additional beta-2 action. So they will never tolerate any alpha blockade or vasodilatation. When this patient was started on amlodipine blocked, patient had no intraoperative problems. Third patient, This was a 12-year-old, again a metanephrine secreting, adrenergic phenotype. This again will have a beta-2 action. Hence, this patient cannot tolerate any alpha blockade. This patient in addition had a TOF, tetralogy of Fallot, which complicates the matters. This patient was started on prazosin because she needed TOF surgery. Her blood pressure fluctuations were so bad, she even ended up in ICU with cyanotic spells. So this patient again, we tried calcium channel blockers and her TOF surgery was successful. So this was the genesis of this study. When we can use calcium channel blockers in dangerous situations where alpha blockade is not to be used or patient cannot tolerate, can it be used as a first line? This was published in JCM recently. Preoperative amlodipine is efficacious in preventing intraoperative HDI in pheochromocytoma, a pilot RCT. So this was to compare the efficacy of preoperative calcium channel blockers. In our case, we used amlodipine versus alpha blockers, prazosin, which is commonly used. And we looked at intraoperative hemodynamic instability in PPGL patients. As we see, the mortality of pheo currently is only 1%. So if you want to use mortality as an indicator, you need about 8,000 patients to study. So this was a pilot open label single center randomized trial done at KEM with ethics committee approval. The inclusion criteria was adults who were 18 to 70 years, solitary, secretory, not metastatic PPGL. And exclusion was inoperable PPGL, pregnancy, or any psychiatric or cardiovascular morbidity, or when patient could not consent. So what we did, there were two arms who were randomized, permuted block 2. First arm, standard blocking, prazosin XL, which was escalated as advised up to day 9 to 30 mg. Second arm, amlodipine, which was escalated faster. We could escalate amlodipine only in 6 days, up to 20 mg. So what we considered was adequate when supine blood pressure was less than 130/80 and standing was more than 130. If BP was not controlled, telmisartan and clonidine were our rescue drugs. And when the heart rate was not controlled, patient were added on metoprolol. So what we did, after we blocked the patient for 7 days in amlodipine and 10 to 14 days in prazosin as advised, we did ambulatory BP recording, which showed what was the evidence of blocking or what actually happened to the patient, because we measure only twice a day. We wanted to know what happened 24 hours. 1 day before the surgery, we gave 1 liter of fluid, and intra-op patient, all patients were operated by a single surgeon, by a single team of anesthetists. So there was homogeneity, and intra-op invasive blood pressure recordings. This is not minute to minute blood pressure. This is actually beat to beat. If, for example, patient's heart rate is 140, we see at what beat the blood pressure was highest and at what beat blood pressure was lowest. And vasodilators, inotropes, and fluids were also recorded. So because it was a randomized trial, when you look at the baseline characteristics, we had about 9 patients in prazosin arm and 11 patients in amlodipine. They were reasonably matched. The duration of blockade, as I said, prazosin required longer blockade, amlodipine required shorter blockade, so that was significant. And one thing which could not be randomized properly was there were more epinephrine phenotype in prazosin, whereas less in amlodipine. So when you come to primary outcome, which is the hemodynamic instability, which is defined as more than systolic, more than 160 of SBP and less than MAP of 60% total time. What we found was there was a stark difference. Amlodipine was only 1.3%, whereas in prazosin it was about 18%. Now look at the blood pressures. Blood pressures more than 250, 44% in prazosin, 66% more than 200, 70% more than 180. Look at the amlodipine arm. No blood pressures more than 250 or 200. And these are all intra-op invasive blood pressure monitoring, by the way. And this, even the lower hypotension was more in amlodipine, is at 89% and 45% in amlodipine. So this shows that this was statistically significant. The duration of HDI, hemodynamic instability, was 18% and 1.3% in prazosin and amlodipine. And look at elevated blood pressure of more than 160 and hypotension also were significant. And if you look at it, the NTG use, which is an indirect marker of how much hypertension has happened, was also more in prazosin, but statistically not significant. This is a graphical representation of, again, bit to bit. If you can see, this is the prazosin arm, this is the amlodipine arm, and this gray area is our normal blood pressure. If you can see this, most of the patients with prazosin, intra blood pressures were ranged up to 200, 300. It is going even to 200. This line indicates the adrenal ligation. Look at the amlodipine, flat lines. Most of the patient had flat lines, and the blood pressure was in good control, intra-op. So this is the only prospective study with randomization, homogeneous surgical anesthesia protocols, bit-to-bit intra-op recording, ambulatory blood pressure, and use of maximum doses. This was, since this was a pilot randomized trial, this was a small sample size, open label. Have people used CCBs before? Are we the only people using CCBs? No, they have been tried before, but there they've used nicardipine. The difference between nicardipine and amlodipine is amlodipine in addition blocks N-type channel. So that the release of catecholamines is less. So these patients, there was no difference. What it means is amlodipine was similar to prazosin. So one of these studies have recommended that you can even use calcium channel blockers instead of prazosin. But these are all retrospective studies, as I said, and the quality of evidence is poor. The only other randomized trial, but this looked at 2 alpha blockers, phenoxybenzamine and doxazosin. Here, if you can see the HDI in phenoxybenzamine, which is the recommended drug, which is supposed to be non-competitive, long-acting, was still 11%, and doxazosin was 12%. This is 134 Netherlands group. So in our group, if in our study, you can see that prazosin was 18% and amlodipine was 1.3%. So what are the mechanisms? Is there a physiological basis? See, this is where your prazosin acts at a very proximal end, which is alpha 1. When you look at amlodipine, this acts more distally at calcium. So what it does is it acts distally. There are additional vasoconstrictors which are known. Neuropeptide Y, which is additionally blocked by calcium channel blocker. And the third point which I mentioned, which is different from nicardipine. So nicardipine may not have been that good previously. This additional N-type calcium channel blockade, which reduces tumoral release when they handle the tumor. So to summarize, amlodipine better in your epinephrine or dangerous type of tumors, or in patients who cannot tolerate even a little bit of hypertension. Example is TOF. In normotensives and paroxysms, guidelines say that in mild hypertension, you can consider calcium channel blockers. But what we say is in normotensive and paroxysms, when they're having paroxysms, blood pressure high is agreeable. During the normotensive episodes, they can have more hypotension in prazosin arm. Why is, and concern for orthostasis and salt and water. Why is that significant? See, prazosin is known to have a differential action. This is according to mechanism. It acts more on venules, less on arterioles. So you'll have a lot of orthostasis requiring a lot of salt and water. Amlodipine has similar action mechanism wise. So arterioles and venules are acted similarly. So what happens is the orthostasis and salt and water is less. So cost, duration of block, and we have started blocking patients on OPD basis with amlodipine. And duration of block, as I said, 7 days patient is ready. Here, 10 to 14 days. So to conclude, preoperative blockade with amlodipine was more efficacious than prazosin in preventing intra-op HDIs. However, larger studies are definitely needed with phenoxybenzimine or doxazocin. So clinical implication is amlodipine is efficacious, safe, convenient, and cheaper alternative to alpha blockade. Even we can block patients on OPD, which we have started doing in KEM. Thank you.
Thank you, Rohit, for the nice presentation. Now we'll move on to the next presentation by Dr. Prasanna.
Good evening, respected teachers and my dear colleagues. I would be speaking against the notion for the use of CCB in patients with FEO against the conventional alpha blockers. Now coming on to the broader picture, as my learned colleague has only focused on a case-based scenario and on a small randomized controlled trial, I would slightly tell in a concise form the broader picture. Pheochromocytoma are rare neuroendocrine tumors arising from the chromaffin cells of the adrenal medulla. About 10% of the pheochromocytomas are malignant, and around 40% of they arising from the symbiotic paraganglionoma are also malignant. And taking malignancies into consideration, surgery is the first line management. And these are the risk factors that have been proposed for hemodynamic instability. That is the large tumor size, that is more than 3 to 4 centimeter, and high catecholamine levels, and preoperatively uncontrolled blood pressures and orthostatic hypotension. These are the goals of preoperative hypertensions that have been recently changed. That is blood pressure control of less than 130 by 80 is needed in sitting, and more than 90 mm per Hg is needed in standing position, with a heart rate of sitting of 60 to 70 and standing of 70 to 80 per minute, restoring the circulating blood volume such that in post and perioperative period we are able to decrease the use of inotropes and crystalloids and colloids, and improving the metabolic function and preventing catecholamine storm and hemodynamic instability during and after surgery. This is the consensus statement that has been published in the guidelines for pheochromocytoma and paraganglioma in JCM in 2014, which recommended that all patients with a hormonally functional PPGL should undergo preoperative blockage with possibly alpha channel blocker as the first choice. And as we know that guidelines are made for a larger chunk of patient that covers a majority of patients up to 90%, and only 10% we need to go off the record. And therefore, I would be suggesting that for a tailor-made approach for each patient to cover that 10% also. And these are the recently published guidelines in 2020 in the journal of by the endocrine hypertensive group of the Endocrine Society of Hypertension. They have also suggested in 2020 itself, with a large chunk of data supporting the fact that adrenal alpha blocker should be considered as the first line of management, and they should also be considered in normotensive patient with PPGL with an increased risk of intraoperative hemodynamic instability. Now, I would be covering slightly in detail the mechanism of action that has already been proposed. That as we know that pheochromocytoma have an increased risk of release of norepinephrine from the tumor per se, and which acts on alpha blockers. Therefore, alpha blocker act as a much higher level and a proximal level as compared to CCB. And as we can see that alpha when alpha receptor are activated, it leads to release of phospholipase C2, which causes a release of inositol triphosphate, therefore decreasing the cytosolic calcium content. Now, this cytosolic calcium content which is responsible for the contraction of the smooth muscle, and not the calcium that is entered via the L-type calcium channel. So this should be segregated and should be kept in mind strongly. Now coming on to the action of alpha blockers that are not met by the CCB, it inhibits vasoconstriction, which can cause hypertension, arrhythmia, or even myocardial infarction. It also permits the expansion of the intravascular volume, and it reduces the frequency and the severity of intraoperative hypotensive episode. It also causes resensitization of adrenergic receptor, which are desensitized by the prolonged action of norepinephrine and epinephrine released from the tumor per se. Now, a large amount of data is in support of alpha blockers, though very low evidence data is available in the form of retrospective studies and case reports, but still data of about 48 years is available, which was published by Goldstein et al. In 1999. They showed that perioperative complications with the use of alpha blockers have decreased from in 69% patient of alpha blockers with respect to only 3% with alpha blockage. And in different series, perioperative mortality have also decreased without the use of alpha blockage from 13 to 45% to 0 to 3%. Now, an additional benefit that we get from alpha blockage is that as we know that in around 10% of the patient with pheochromocytoma have catecholamine induced cardiomyopathy, because the excess circulating catecholamines cause direct toxic injury to the myocyte, thereby decreasing the systolic functions and causing dilated cardiomyopathy. Alpha catecholamine excess can also lead to coronary spasm that may lead to myocardial infarction, and catecholamine excess also leads to increased permeability, thereby pulmonary edema and myocardial hypertension, and myocardial stenting can also be caused due to catecholamine excess. Therefore, action of alpha blockage is strongly recommended in patients of cardiomyopathy, and prolonged duration of alpha blockage is needed to avoid such events. Now, this was a very interesting case that was published as a case report, in which a patient who was recently been diagnosed with a pheochromocytoma encountered a myocardial infarction and was admitted with poor ejection fraction and global hypokinesia, and he was not able to cope up even with the increasing dose of vasopressors with epinephrine infusions. But when alpha blockage was added to the cocktail, it increased the ICU settings. ICU people were able to taper the dose of norepinephrine, and the patient's clinical condition improved. There is also evidence against CCB that calcium channel blocker can only be added to alpha blockage due to paucity of data that is available in support of CCB. Therefore, CCB are not recommended as a monotherapy unless there is normal or mildly elevated pre-op blood pressure levels or severe orthostatic hypotension during a course of alpha blockage that has been given. Now, coming on to the studies that are not, I would rather say not against CCB, but less favoring CCB. There was a study done by Le Buffet et al. In 2005 based in France. They retrospectively inspected 105 patients. In 65% patients, they showed a transient intra-op hypotension in patients on CCB, and a continuous nicardipine infusion was needed to be given during the surgery for blood pressure control. Therefore, they concluded that the sole use of CCB does not prevent all hemodynamic changes. However, its use was associated with low mortality and morbidity. Another study that my learned colleague also mentioned, that Brunod et al. In 2014, it was a study based in USA and France, retrospectively inspecting 155 patients. 110 patients received CCB and only 41 patients with alpha blockage. On comparing nicardipine with benzodiazepine, they found that in tumors of size more than 3 centimeters, they had more hypertensive episode with CCB than with alpha blockers. As we can see that the tumor in patients with tumor more than 3 centimeters, there is drastic difference between the systolic blood pressures intraoperatively as compared to the pheochromocytoma. with all values in the with significance levels. Another study that my colleague discussed was based in Mumbai, as we have already seen its effect, and it was a very nice and very well done study with no perioperative mortality in either of the group, either in the amlodipine group or in the prazosin group, and they concluded that amlodipine can be efficacious alternative to prazosin. But I would like to point out some of the shortcomings, that it was a very small cohort of only 23 patients and this was an open label study, and they in their exclusion criteria they specifically mentioned that patient with cardiomyopathy was excluded. But as you have already pointed out, that it is already present in about 10% of the patient, which can be subdued or latent. Therefore, when using CCB in a patient of cardiomyopathy, it can lead to adverse effect. And patient with metastasis and multiple pheochromocytoma were also excluded from the study. So we were not able to look into what are the response of CCB on metastatic and pheochromocytomas. And as already data is available with alpha blockers on these pheos as well, therefore I would bat for the alpha blocker in a broader perspective. And they also did not mention with the baseline levels of catecholamine metabolites, as already I have indicated in the risk factor for considering patient with tumorous surgery, that high catecholamine level do pose a danger for during intra-op period. Therefore, the more experienced molecule should be considered, that is alpha blocker, for their management. So I would conclude with my points for alpha blockers, as they handle hemodynamic instability much better. They control the BP fluctuation in the pre and intraoperative period, and have been found to be efficacious with or without cardiomyopathy. And benefits have also been seen in normotensive PPGLs, as we also find its effect in the recently published guidelines, and large sets of data are available for clinical outcomes as well. And against CCB, I would like to highlight, it has a common inotropic effect on the heart. Therefore, as with the alpha blocker, CCB also cause a reflex tachycardia. So for managing that tachycardia, we need to manage them with beta blockers. And as we know that when CCB are used with beta blockers, they tend to precipitate CHF, and they have a additive negative chronotropic effect and cause heart blocks. And limited experience is available with CCB use in PPGLs, with limited effects on severe hypertension. Patient have not been yet managed with CCB because of small cohort size, as we have seen, and metastatic disease and high catecholamine excess state have not been studied with CCB. So therefore, the study also indicate that CCB should not be considered in pheos larger than 3 centimeter size. And as my learned colleague has also said, that higher level of orthostasis is also seen in cases of alpha blocker, but that is on the beneficial front, because as we know that patient with pheochromocytoma due to catecholamine excess have been associated with volume contracted state, and when we use alpha blocker, there is a chance for volume expansion with salt and water, such that post-operative hypotension is encountered in less and less number of patients. So I would conclude with these take-home messages that patient with comorbidities to be considered on starting a patient with alpha blocker or with CCB, and baseline tumor characteristics should also be considered, such as tumor size, hormonal activity, and metastatic disease before starting any drug. And drug availability and affordability is always an issue, and scope of evidence states that, as mentioned in the guidelines, alpha blocker is currently the management of choice, and institutional experience also matters, because in most of the elite institutes which have been alpha blockers have been being used for a long period of time. So with due experience, we need to bat for alpha blockers.
Thank you.
So, Dr. Rohit, do you have any points to counteract whatever that has been said now?
Yes, sir. I thank my colleague for his comments. My rebuttal. First, consensus statement or guidelines. 2014, they say that alpha blockade has to be used. This was based on Goldstein study. Now, if you look at Goldstein study, the data goes for 50 years, 3 different protocols used, 3 different surgeons, and they say that that was not the primary outcome. Their primary outcome was what happened to the patients. They say that the anesthesia and surgery improved, hence the mortality improved from 67% to 3%. They don't say that it's because of alpha blockade. They say by the by that alpha blockade may have contributed. That is one. So guidelines are based on only retrospective study. So the guidelines are not soundproof. Second, they mention in the guidelines when you read, we need larger studies. We cannot take the evidence for alpha blockades is very low, but we cannot take off alpha blockade because of the catastrophic consequence which outweighs the benefit. The risk outweighs the benefit. This is what they talk. Sorry, benefit outweighs the risk. That is why we say you use alpha blockade. There's no evidence. Second point, they say that calcium channel blockers increased in hemodynamic instability. Now, when you look at the latest publication by Castanetti in 2020, they found that alpha blockade, when they used in patients versus no blockade, they found that alpha blockade, there was more hemodynamic instability. So alpha blockade made patients' intradynamic hemostability worse. So that also I don't agree with. Second thing, all the studies which have been quoted are retrospective, no homogeneity in the data. So evidence is very low. Fourth point, cardiomyopathy. Alpha blockade, he says that cardiomyopathy is better. There's an article by Goffrin et al. Which clearly says that this coronary spasm is reduced by calcium channel blockers. So calcium channel blockers is actually better when you look at cardiomyopathy, as was seen in our patient. The other point he mentioned about the recent guidelines of a Journal of Hypertension 2020, that was published before our study was published. So I don't know what will happen in the future. Then when you look at again CCBs, he quoted 2 studies, Leboeuf 2005 and Brunold. So what they used was nicardipine. As I clearly mentioned, amlodipine is way better than nicardipine because of your additional N-type action. That's what I'm trying to tell. And in those studies also, they found that nicardipine was non-inferior to alpha blockade. So they only suggested that you can use calcium channel blockers. What in addition I'm trying to tell you is amlodipine blocks N-type channel, hence intratumoral release of catecholamine is reduced, hence it is better than nicardipine. The last point about our study, definitely our study is small. It is a single center study, but you should understand that in pheochromocytoma, homogeneity of the anesthesia and surgery plays a big role in doing study. One. Second, when you have a negative study is when you need a larger study to improve your power of the study. That's what they say. When you already get a positive result on small numbers, they say that when you do larger studies, it is only going to get amplified. And he mentioned that baseline catecholamine levels were not mentioned. They were actually mentioned. And as I said, prazosin had more epinephrine group. And the conclusions that beta blockers, in addition to calcium channel blockers, causes heart block, that is, I think, true for non-dihydropyridine, whereas amlodipine is a dihydropyridine and it does not have direct chronotropic action. So definitely it causes tachycardia. So at KM, what has happened because of this study and this thing, our practice has changed. We have moved to only amlodipine. Prazosin has moved out of vogue. Amlodipine for 6 to 7 days. Tachycardia sets in. See the blood pressure. Start the patient on fluids or salt. And metoprolol if the patient has tachycardia. We are continuing to get good results. After the study, we might have blocked about 25 to 30 patients. And we are continuing to get good results. So finally, we definitely need larger studies to compare with phenoxybenzamine or doxazocin. But it is very difficult. So this is what I would say. Thank you.
Hello. You see, the KM study is very nice and nicely done, but a little underpowered because their sample size was originally to be 26. Then they recruited and randomized 23 patients. And finally, the result was analyzed only on 20 patients. Secondly, if you look at the presentation of hypertension in pheochromocytoma, that is also very, very heterogeneous. In your paper, only one, you had said that one patient had to be dropped out because the blood pressure was so difficult to control that you had to use alpha blockers as well as calcium channel blockers. So far, the experience is very, very minimal, and one cannot generalize it across all the manifestations of pheochromocytoma. And at this juncture, one needs to individualize. Like some patients are asymptomatic, they are non-hypertensive. Now, how many patients in your study had no hypertension?
Small number were normotensives. About I'll say about 3 to 5 were normotensives. Everybody was hypertensives.
But how are they randomized into the groups? Equal this thing, or one group had more normotensive and the other group had less normotensive?
Sir, there was no statistical difference between hypertensives and non-hypertensives between the two groups. The number I forget, it's about I think 3 and 2 or something like that. And they were secretory phenotype and.
True. So that's what I want to make a point. So far, what has happened is our experience has been huge with alpha blockers for last so many years. This is a new concept. And looking at the heterogeneity of the manifestations, it is very early to say that amlodipine can replace alpha blockers at the moment. Dr. Sahu, do you have to say anything?
Yes, sir. I would like to add 2-3 points. Sir, as you have mentioned, the alpha blocker is a time-tested drug. So definitely there is a huge experience. And the second thing is it not only improves perioperative morbidity, also it improves the mortality. But as Dr. Rohit has presented the literature and their paper, the study from their own institute. So I also would like to highlight there is definitely some role of CCB, particularly those who are mild form of pheochromocytoma, particularly purely epinephrine secreting, where there is normotensive or mild hypertensive with fluctuating blood pressure, or the patient having cardiomyopathy, or as a top-up drug where the alpha blocker is not sufficient enough to control BP. Definitely there's a role of CCB. But as of now, based on the huge amount of data in favor of alpha blocker in the literature, so CCB, we cannot replace alpha blocker with CCP for classical cases of PO with hypertension, particularly as Dr. Prasanna has presented data, particularly the patients having a tumor size more than 3 centimeter, difficult to control, underlying cardiomyopathy. Those conditions, maybe we should not bring CCB as the first choice. Hello, sir.
Yeah, sorry, that got interrupted a bit. So basically,
Sir, please carry on, sir.
No, the treatment, I think, should be individualized as per the patient profile. That should be the take-home message rather than generalizing it, saying that the calcium channel blockers are superior to alpha blockers, and that is a very premature statement to make at the moment.
Correct.
Any
So very clear
suggestion
message
from the other
from our faculty. And so at this point, it's early to say, but maybe a role definitely in future. A big round of applause for both our debaters and our faculty. Thank you, sirs, for joining in and giving your words of wisdom. And with this, we come to an end of this debate and move on to the next session of the day, which is an interesting dialogue on primary hyperparathyroidism. We have two renowned experts in the field. We have with us Professor Deepak Abraham, who's the head of endocrine surgery department at CMC Vellore. And we have Professor Satyanath Mukhopadhyay, who's a senior professor of endocrinology at Calcutta. And I think Sir would be joining online. To present a case and take us through this dialogue, I have the privilege of inviting Dr. Jinsun Paul, who's an assistant professor in the Department of Endocrine at CMC Vellore. I invite Professor Deepak Abraham to please come on stage. I welcome Professor Satyanath, who has joined us online, and I invite Dr. Deepak.
Hope I'm audible. Can you just check?
Yes, sir, you're audible.
Fine, thank you.
Thank you.
Good evening, all. We will straight away go to the case. So this is a story of a 75-year-old male with a history of renal calculi, which was detected 1 year back. And he presented to us with severe fatigability for the last 6 months. There was no history of any fractures, bony pain, constipation, or altered behavior. And he was having history of hypertension for 2 years, and BP was stable with 2 antihypertensives. There was no significant family history. On examination, his BMI was 30 kilogram per meter square. Blood pressure was normal. There was no bony swelling, deformity, or tenderness. On neck examination, there was a firm swelling palpable in the left side of thyroid, 2 into 3 centimeter size, moving with deglutition. Right thyroid lobe was non-palpable. Trachea was central. There was no cervical lymphadenopathy. Other systemic examination were normal. Coming to his blood investigation, as you can see here, TSH was normal, and the serum calcium was 1 milligram per deciliter above the upper limit of normal. Serum phosphate was on the lower side. He was having a PTH level of 363 picogram per ml. His 25-hydroxyvitamin D was 22.2 nanogram per ml. And on urine examination, there was hypercalciuria. He has 5 milligram per kilogram per day of urine calcium, and the TMP-GFR was on the lower side. On further investigation, his BMD by DEXA scan showed osteopenia at lumbar spine and the radius, and the BMD at the proximal hip was normal. Summarizing, this patient is having primary hyperparathyroidism with end organ damage, renal calculi, and osteopenia, and he was having a palpable left thyroid nodule. May I ask to Professor Satynath, sir, what are the typical presentation of primary hyperparathyroidism, and how Indian patients with PHPT differ from those in the Western world?
Good evening to start with. I thank the organizers for having me, and good evening, Dr. Deepak. Satynath, I hope you can hear me. Right.
Yes, sir. Yes, sir, we can hear.
Yeah. Now the first question is, I think, entirely in the Western context, because majority of the patients, more than 80% there, are asymptomatic. So if you have a symptomatic PHPT, it's atypical for them, whatever symptomatic you have. But leaving that aside, if you consider 2 scenarios, one is your normocalcemic PHPT, and at the other end of the spectrum, you have severe hypercalcemia, a parathyroid crisis-like situation as a presenting feature of PHPT. So those would be some of the atypical presentations. Now, if you come back to the other manifestations like your neurocognitive decline or neuropsychiatric manifestation, that can be one atypical presentation. And as you mentioned, as the presenting feature, this fatigue, unusual fatigue can be a very atypical presentation of primary hyperparathyroidism. So I hope that answers the first part of the question. Now coming to the Indian patients with PHPT, if you go through the published literature from the Indian PHPT registry, which I'm a part of, you will see certain atypical features like large tumors, palpable tumors. If you get a palpable parathyroid in the Western literature, they will say, unless proved otherwise, this would be parathyroid carcinoma. And that is not the scenario here. And I think Dr. Deepak will also agree. We do see palpable large parathyroid tumors that turn out not to be carcinoma. So that's one presentation. Indian PHPT subjects present earlier than their Western counterpart. We have acute pancreatitis as a presenting feature many a time, which is not reported that frequently in the Western literature. And in the Indian PHPT registry, strong association, I wouldn't say strong, a significant association with gallbladder stone has been reported, 13%. GB calculus in the Indian PHPT registry, which has not been reported from anywhere else in the world. So these are some of the aspects in which Indian PHPT patients differ, and considering their younger age of onset, they have more pronounced bone disease to start with. I think I'll stop there and I can carry on, unless there are any further questions on this.
Okay, thank you, sir. So this patient was evaluated in a nearby hospital, and in view of his hypercalcemia, 2 doses of injection zoledronic acid was given, and he was started on tab cinacalcet 30 milligram once daily, because after zoledronic acid, the calcium level was still remaining high. But he was having persistent hypercalcemia, fatigability, and osteopenia when he came to us. So again, to Professor Satyanath, what are the indications for surgery in primary hyperparathyroidism? For example, in this patient, he was having hypercalcemia, and he was elderly, 75-year-old. He was not having any significant symptom other than fatigability, and he was having persistent hypercalcemia on medical management. So generally, what are the indications for surgery in PHPT?
Right. Before I answer that question, I would like to know 2 things from you. First of all, this patient was obese, BMI of 30. Do you find any connection between PHPT and this high BMI? This is the question to the presenter. I'm sorry. This obesity. Can you hear me?
Yes, sir. Yes, sir.
So high BMI and PHPT, do you see a connection? Or, I mean, this is not for you. I'm sorry. I mean, this is for the students, if they're there. Obesity. Okay, maybe we can take it up later. And no. So, okay. And so the indications for surgery, as you rightly pointed out, all symptomatic patients must undergo surgery, because this is the only curative option unless significant comorbidities contraindicate or preclude surgery. So basically, the question comes, when do you subject asymptomatic PHPT patients for surgery? And there certain criteria have been laid down by the International Consensus Committee, which was set first, I think, in 2004, and then it got revised later on. So younger patients, age less than 50, so they should be subjected to surgery. Why? Because studies have shown that they have more aggressive disease, and that's why they are likely to reap greater benefit out of parathyroidectomy. Then compromised renal function, your EGFR less than 60. Again, surgery has shown that it can prevent the decline of renal function following successful removal of the offending tumor. Osteoporosis, so BMD less than minus 2.5 at any site. That would be another indication. In the patient under discussion here, the bone mineral loss was not that much, and it was a little surprising that while PTH dependent bone loss affects predominantly the distal 1/3 of the radius and the hip, because those are the cortical bone sites, this patient had a normal hip BMD, and BMD at lumbar spine, the T-score was more negative than the BMD at the distal 1/3 radius. Some atypical presentations. Now coming back to the indications in asymptomatic PHPT. So then if you have significant hypercalciuria, while urinary calcium excretion of more than 300 milligram per day would give you a signal, but for the purpose of surgery, calcium excretion more than 400 milligram per day has been taken as the standard indication for surgery. Then your presence of nephrolithiasis would be another indication. I think I'll stop here.
Okay, thank you, sir. So in this patient, we decided to go with the surgery. And initially for localizing, we did the technician 99 MIBI scan with SPECT CT. As you can see in this picture, there was tracer accumulation in the left inferior parathyroid gland. And in the SPECT CT, it was clearly shown as a left inferior parathyroid lesion tracer accumulation. And second investigation, we did the ultrasound of neck, which is showing a lesion of 1.4 into 1.8 into 2.9 centimeter, predominantly solid, isoechoic, wider than tall lesion with smooth margins noted in lower pole of left lobe of thyroid, which is thyroids 3. And in ultrasound of neck, there was no definite parathyroid adenoma identified, and there was no significant cervical lymphadenopathy. So we have discordance between ultrasound neck and parathyroid scintigraphy. So to Professor Deepak sir, so what should be the next step in this patient, and what are the challenges we face in localizing parathyroid lesions?
Yeah, I think we also went through this discussion about a 75-year-old man with no significant end organ damage. Should we consider surgery or not? Should we just keep him on medical therapy? But after our discussion in our MDT, I think his weakness and fatigue was quite significant, and he also was very keen on having surgery. Otherwise, a very fit gentleman. So we went ahead to plan for surgery. And so when we are in a situation like this, when you have planned for surgery and you're looking for imaging, localization, we do both an ultrasound and a MEB. The MEB is a functional image. The ultrasound is a structural image. The MEB is like a ghost. The ultrasound is like a corpse. You got to marry the two. You got to get it right, because you need to work out what is actually the lesion which is causing your problem. And hence the fusion of the structural and the functional resulted in what's called a SPECT CT. And so you have a SPECT which is functional and a CT which is the married structural. So you can see that in the previous image, that's the SPECT CT which is showing an uptake in the left inferior. So we went ahead to plan for surgery, but when we have one image, one modality not showing the lesion, or two modalities showing two different lesions, then we consider to bring in the third modality, which is a 4D CT. And so this is what we did for this gentleman. So we went ahead and did a 4D CT scan, which will come up now. And this time it was actually posterior to the right lobe of thyroid. So it was a separate lesion from what was shown on MEB and ultrasound. And hence, to keep this in mind as clinicians, remember that we go with the first line of investigations, which is ultrasound and a MEB. Add on 4D CT if required, not for all patients. However, people who are from areas where you do not have access to a MEB scan, many of my colleagues in smaller towns and tertiary cities where you do not have an access to a MEB, it's easier to do a 4D CT upfront rather than do ultrasound and a MEB together. So that is your choice. It's how you go about working that patient up. 4D CT is easier to interpret. Only thing you need to know how to administer the contrast for the 4D CT scan. And that is the timing, which is very important in the fourth dimension, which is time. And that is what needs to be worked out well. Otherwise, you'll have a plain CT neck and thorax, and you'll miss the whole lesion. So this lesion now said it's a right, it was reported as right superior. Yeah, you can see on this keys to understand what is superior and what is inferior. A lesion which is more anterior in the neck is an inferior. Lesion which is more posterior in the neck is superior. And in the same superior, you could have a descended superior which can mimic an inferior, and a superior which is located in its normal location. And hence I always tell radiology or nuclear physicians, what you sometimes call as inferior is actually a descended superior. And hence there's an oblique image in the MEB where they can actually look whether it's anteriorly located or more posteriorly located, which can then help us make the call. So in what I've given you as tips in imaging or localizing is first go with an ultrasound and a MEB if accessible. Add on 4D CT if you require, if one of them do not show it, or both of them show two separate lesions or two discordant scans. So this is what came out, and you can read that out, in terms, you put that in terms of time. So there's an intense arterial phase enhancement and a washout on a delayed phase, such suggestive of a right superior parathyroid adenoma.
Sure.
Okay.
Thank you, sir. So to Professor Satynath, sir, so what are the treatment options available for preoperative control of hypercalcemia? So in this patient, we decided to go out with the surgery. Calcium is still high. So what are the options available for us?
Well, first of all, this patient is not having any parathyroid crisis-like situation. So the surgery is going to be a planned one, and we have some time at hand. So what I would like to do first is I'd see that the patient is sufficiently rehydrated. So there is no dehydration. I'll encourage fluid intake, at least 6 to 8 large glasses of water a day to have good urine output. And I would also encourage the patient for physical exercise to avoid, immobility or staying in the bed for long period of time, because both these problems are associated with hypercalciuria. Then I would check the medication list, elderly male person, whether he's having hypertension, he's on a thiazide diuretic. If he's on a thiazide, I would like to stop thiazide. And this patient is having fatigue, depression. I don't know whether the patient is having lithium, which is another cause of, which can mimic PHPT or can aggravate hypercalcemia in PHPT. So if possible, in consultation with the psychiatrist, I would also like the patient to go off lithium if he's already on this medication. Now, leaving aside those interventions, when it comes to actually medically control hypercalcemia, I wouldn't go for, I think I saw that slide somehow. So before zoledronate was given. So unless there is a significant bone disease, to control hypercalcemia, I would not use zoledronate as the primary modality. I would rather go for cinacalcet. And the starting dose recommended is 30 milligram twice a day or 60 milligram once a day. So it's not surprising that his hypercalcemia was not controlled with 30 milligram once a day. That I think was a too low a dose. So these are the modalities available for preoperative control of hypercalcemia.
Okay. Thank you, sir. So this patient was given oral and IV hydration, and the cinacalcet dose was increased to 60 milligram once daily. And preoperatively, the calcium became 10.07 with a phosphorus of phosphate of 3.4 and albumin 4.2. So, Professor Deepak, so what surgery should be done in this patient, and what are the surgical options available for primary hyperparathyroidism?
Okay, so this patient had a 3 centimeter thyroid nodule, which was associated with the parathyroid adenoma, which was posteriorly located. So we counseled the patient and said we could consider doing only the parathyroidectomy, or we could consider doing both the thyroid and the parathyroid. And so for this patient, we actually did both. And that was after this patient's daughter is a medical person in Australia. So I had to actually have multiple WhatsApp calls with her to make the decision. And finally, we decided to do a thyroidectomy plus a parathyroidectomy. So we went ahead and did a total thyroidectomy and a focused right superior parathyroidectomy. And that was what was planned. And what we wanted to rule out was whether there was, hyperplasia, because the other gland was reported as left inferior, but it was finally a right superior. And we did a biopsy of one of the glands. And so that's what we did, a total thyroidectomy plus a right superior parathyroidectomy and a biopsy of the left superior parathyroid gland.
Thank you, sir. And the postoperative day 1, the serum calcium became 9.1 with a phosphate of 2.2 and a parathyroid level of 4.6 picogram per ml. So to Professor Satyanath, what are the complications or especially medical complications we should anticipate during postoperative period and how to manage them?
I think Dr. Deepak Abraham did the surgery, so it will only be in the fitness of things that he talks first. Over to you.
Yeah. Okay. So the first thing, I just like to also highlight the use of another adjunct, which is intraoperative PTH. Now, we do not have an intraoperative PTH machine in the theater, but we work with the biochemistry and say that we will be sending samples to you, and we actually get the ice to the theater, we collect the pre-incision sample, or we sometimes do the pre-excision sample. So it's a pre-incision sample followed by we'd send only 2. So we modified the Miami criteria, and we take 2 samples, which is the pre-operative and the 10 or the 20-minute post-operative, post-excision, not so post-operative, post-excision. So once the tumor is out, we send that sample. And by the time we close, we often get the result back, which takes about 25 minutes for them to run. So this patient, we did not use it because it was clear-cut an adenoma, which was over 500 milligrams, and the other gland was very small. Other glands were very small. So we did a total and a post. So what we see, what is remarkable about this patient, I can tell you, he was so happy that he said, my fatigue is gone. It was miracle. It was actually, he could get up from bed and say, all my pains have all gone. He had a complication. His complication was he had a vocal cord palsy. He couldn't have a voice. So I was expecting to handle a patient who's with all the social network around, that I've got a vocal cord palsy and a hoarseness of voice, and he had a completely hoarse voice. And I didn't understand why, because operation went smooth. The nerves were okay. Only thing, he had a short neck, he had a little bit of extension. The thyroid nodule was a little prolapsing down. So he had to rotate the gland a bit. And so was there a traction on the nerve. But in spite of having no voice, he was so happy that he could actually get up and walk and say, oh, my pains have all gone. That's how dramatic parathyroid surgery is for patients who's symptomatic from that. We had another patient who said, I couldn't clap, but today I can clap. That was immediate, like 2 hours after the operation. So the complications we expect, apart from the surgical complications, is significant hypoparathyroidism from, especially if you've got significant bone disease. And you will have that in patients who you will certainly have to give a lot of IV calcium for them to sort of be, maintaining calcium homeostasis. This gentleman did not have that. His calciums dropped, his PTH dropped, but he had no voice. And but in spite of the fact that he was so happy that he says, I can, all my stiffness in my hands, my body is all gone. I feel that I've become a new person. That was the exact words he used, that I've become a new person after this operation.
Professor Satyanath, you want to add anything on the?
Yeah, just to comment on the phosphate level, it dropped following surgery.
Yes, sir.
So if you have a low phosphate and that is coupled with a low calcium, then of course with low PTH or normal PTH, you would suspect a hungry bone. And this patient had significant bone disease pre-op, so it's not unlikely for him to have a hungry bone. Only catch here is that the serum calcium looks normal. In this situation, I think if the patient has symptoms suggestive of hungry bone or hypocalcemia, say those paresthesias or tetanies, things like that, then I would also check an ionized calcium here at this point to see whether the ionized calcium is low, the phosphate is low, PTH normal or below normal. So whether the patient is going into a hungry bone kind of a situation. That's all I would like to add here. Thank you.
Thanks. So what about long-term follow-up, sir, in this patients too? Professor Deepak, how will you follow up this patient after surgery?
Yeah. What I do is I send them to the endocrinologist.
So it's over to me.
So yeah.
But before I start,
I would like to just comment on this gentleman, because I had to we have a close association with him because of his not immediate long-term follow-up, but at least his immediate follow-up because of his voice. And we couldn't explain. We actually went to the voice clinic, the specialist, and they looked at it and said, actually, they did an EMG to see if the muscle is being stimulated. Yes, it was. So something was wrong. Why was his voice? So they repeated a CT scan post-operatively. He had a aneurysm of the ductus arteriosus, which had thrombosed. Now that's as rare as you can get a complication for why a left nerve which hooked around that thing has got palsied. Now this gentleman is still under follow-up. His voice is just coming back from voice therapy. But that was the reason why we found out when did he have this aneurysm and when did it thrombose, we don't know. But possibly in the post-operative period, with all what we did, has possibly caused it to happen, and hence his that explains why his vocal cords were gone. He's anyway getting better, but what I would do in a patient like him is check his biochemistry in a 3 months period of time, then assess bone health. If there was significant bone loss earlier, which this gentleman did not have too much, and hence would have just kept him, he would be doing fine post-op.
Professor Satyanath, you want to add?
So I think I have a little more to add, except to say that post-operative calcium, we usually do 6 to 8 hours after surgery. That is in the evening. The surgery is done in the morning, and the calcium comes down following successful surgery. PTH, we check in the next morning sample along with another calcium. And then once the patient goes home, this patient did not have significant hypocalcemia. So after discharge, yes, biochemistry at 3 months, then maybe at 6 months, and then repeat BMD at 1 year from the date of surgery. And then we would like to follow the patient annually thereafter. But if the patient has post-operative hypocalcemia of a permanent nature, that becomes a challenge. But I don't think we have the time to discuss that. But in such a patient who would necessarily be on a combination of calcium and a calcitriol, we would also check the patient for hypercalciuria at least annually. And maybe if there is a signal of renal involvement, nephrolithiasis or nephrocalcinosis, so annual ultrasonography also I would do in my own practice. Thank you.
Okay, thank you, sir. So this we come to the end of the program. So thank you, Professor Satyanath sir and Deepak sir for the.
Thank you. Thank you very much.
Thank you. Thank you, Professor Satyanath.
Thank you, Professor Deepak. Thank you. Bye.
Thank you, sir. It's a great learning experience. Thank you, Dr. Jensen, for that presentation. And with this, we come to an end of today's session. We do have the preliminary round of the quiz planned now. So I would request you to rearrange yourself in your teams of 2 people and be seated in this room for some more time. Just a few housekeeping appointments. I did see a lot of you were trying to click a lot of photographs for slides. I'm glad to share that you would have access to the whole presentation. It's already on YouTube. I was just seeing we have about 27 people watching live at this point in addition to you. So last time we did have a feedback when we did it on Zoom. We couldn't download and store it for a long time because on the cloud it went away. But this time we have it on YouTube. So you would have everything as recorded forever for you to go back and listen. We do have the preliminary round now, and after that, all of you who are staying in Benz Park would have your dinner at the hotel. Tomorrow morning is a very early day. We did try and think that we make the best of your time here, and that's why we are planning to start really early. Your breakfast in Benz Park would be available from 6:30 a.m. and we would want you to reach here latest by 8:15 a.m. We would start the workshop sharp at 8:30. For the endocrine PGs from our department, you have your packed dinner here. Please make sure you collect it before you leave. And tomorrow morning, we will reassemble here by 8:15. So over to Dr. Ramya, who will conduct the quiz for the preliminary rounds. I request all faculty to join for dinner in the faculty lounge. Thank you.
So we have a total of 25 entries for the quiz. So I request you to relocate yourself with your team members. And we have three separate entries. Dr. Aruna from MKCG Hospital, Dr. Arijit Sinha from IPGMR, and Dr. Sandeep Kumar from KM Mumbai. Maybe if you are wishing, two of them can club together to form a single team. And you have a total duration of 30 minutes for the quiz. Each correct answer will carry 4 marks, and each incorrect response will give you a -1. And I request you to write the team members, both the team members' names in the paper, as well as the phone number.